Oh, static recording?
Yes. I'm not sure who's. Okay. Oh, everyone's joining. Let's just give everyone just a moment to record some more. For the moment being, we will ask everyone to mute themselves just for, except for Dean Goldman. So Tanzanian. Liberata. Sorry, we're just going to give everyone just one more moment to join in. Your Excellency Mulamula, we will be muting you just for a moment because we're going to begin with Dean Goldman's introduction for the Health Summit. Okay, so we can go ahead and begin. Hello and welcome to day 2 of the first annual GW Health Summit. My name is Adam Snyder, president of the American Medical Physiology Club, and I'm thrilled to be co-hosting the GW Health Summit today alongside my fellow co-hosts you'll be meeting later today. The GW Health Summit serves as a platform to enrich the educational opportunities of the next generation of health and wellness leaders. In this pursuit, we are offering all event participating students various opportunities for linkage to our free mentorship program, upcoming network events with healthcare professionals, and inspiring webinars. This Health Summit is the pinnacle of the pursuit of academic and professional excellency. This weekend, we are joined by our nation's greatest healthcare leaders and forward-thinking minds. Yesterday, we had the great pleasure of speaking with the 17th Surgeon General, Dr. Richard Carmona. And today, we are honored to speak with the Tanzanian Minister of Foreign Affairs, Her Excellency Liberata Mulamula. We will feature 3 panels discussing sexual/mental health, healthcare administration, and medical innovation. And now I'll hand things off to my co-host, Aditya Langanathan.
Good morning, everyone. My name is Aditya Loganathan, and I am a representative of the Global Student Surgery Alliance and Hippo Helpers. I hope everyone is having a wonderful morning so far, and I want to start by thanking all of you for your attendance and your continued support of this year's GW Global Health Summit. Without all of you, none of this would be remotely possible. I want to thank today's speakers and panelists for taking the time out of their busy schedules to come and speak with us. And I want to especially give a round of applause for moderators and event coordinators for working so hard this past month to plan this event. Especially Adam Snyder has been working nonstop for the past few days to ensure this event runs as smoothly as possible. Now, before we begin with today's events, I want to introduce Dr. Lynn Goldman to say a few words and provide today's opening remarks. Dr. Goldman is a pediatrician and epidemiologist and dean of our very own Milken Institute School of Public Health. Dr. Goldman, the floor is now yours. Thank you once again for coming to speak with us.
Thank you very much. And good morning, everyone, or afternoon, depending on where you are on the planet at this point in time. It is my pleasure to welcome you to this first year's, actually, Health Summit. I don't think any of us could have imagined that we would, for a second year in a row, be holding meetings like this virtually. But the good news is, with the vaccine rollouts worldwide and continued masking and social distancing, that perhaps this will be the last time. During this unprecedented time of disease, racism, and violence, there are also reasons for hope. We have learned so much in the last year. 1, the importance of rigorous training in medical and health sciences. Public health, medicine, nursing, and other health sciences need a national and indeed global reinvestment. We desperately need to address the shortages in trained leaders, experts, researchers, and practitioners. 2nd, though, the importance of working with communities. I think we learned it's not enough to develop effective vaccines using cutting-edge technologies. We also must get those vaccines to people. We need to develop the logistical, the community, the behavioral strategies, the global health strategies to get vaccines into people. We've learned more recently, mask mandates are great when they are science-based, but confusing when workplaces, communities, and families can't figure out how to implement them. The importance of putting prevention first is another lesson we've learned. In other words, when we err, if we make the wrong choice, we need to err on the side of protecting the public. That is why we trust Dr. Fauci. We know he bases his views on science, but we also know that he is leaning toward what needs to be done to keep us safe. We've also learned the importance of addressing inequities wherever we find them. The inequities of health and healthcare that have always existed in our society and, in fact, globally, have become enormous chasms in the context of the pandemic. Let us not forget the lessons learned. The health of Black, Latinx, Indigenous people, the barriers to access among the LGBTQ communities, the unequal care that is given often to the elderly, and particularly the terrible conditions that we have allowed to exist in places like assisted living facilities and jails. All of these inequities became visible as enormous causes of death during the COVID-19 pandemic, and in fact, that we're still seeing globally. I know that some, if not all of you, have lost families and friends due to the pandemic, and that many have suffered from stress created by sometimes even too much Zoom and too little face-to-face interaction. And my heart and support goes out to each and all of you. But this is truly your moment to shine. The world needs highly trained and skilled health experts more than ever. I recognize and applaud your passion and commitment as demonstrated by your being here on a Sunday. My advice to you, first, always ask questions. Learn how to ask the right questions. Don't be too quick to give answers. I think the pandemic taught us that. But second, build your network of colleagues, mentors, and friends. I can't tell you how often I was able to call upon people in my network to help support me over the last year in my decision-making. And this conference and organizations like this are a great opportunity for you to do that. So here's to a great day that I hope will inspire and energize you, as well as help you build your own professional network. Have a wonderful conference today.
Thank you so much for coming out today, Dr. Goldman, and speaking for all of us. It was very insightful. I would now like to introduce Caitlin Yuan and Adam Snyder to moderate the next event featuring today's keynote speaker.
Good morning, all. I'm Caitlin Yuan, your moderator for this session. I represent Isaac, and today we present to you Her Excellency Ambassador Liberata Mulamula, Minister for Foreign Affairs of Tanzania.
Her Excellency Liberata Mulamula is serving as the Minister of Foreign Affairs of Tanzania, and she's previously served as a Tanzanian ambassador to the United States and was promoted to the relations between the two countries to greater heights. She also served as a senior diplomatic advisor to the former president of Tanzania and as the first executive secretary of the Region Intergovernmental Organization for Peace, Stability, and Development in the Great Lakes region. She was a visiting scholar and acting director of the Institute of African Studies at the Elliott School of International Affairs at the George Washington University. She is a recipient of the Order of United Republic of Tanzania 2015 Award for Distinguished Public Service.
Today, Her Excellency will be speaking to us about women's leadership in the context of healthcare, development, and empowerment. Please welcome Her Excellency Liberata Mulamula.
Hello, everyone. I know some is good morning, good afternoon, good evening. It is good evening here in Tanzania. I'm so delighted to join you. And thank you so much for organizing this important summit. But I want to start by thanking Adam Snyder and Caitlin for organizing this summit and inviting me to participate in this, of course, highly important and technical, actually is a technical summit. I am, of course, technologically challenged. Therefore, I wasn't able to prepare a PowerPoint presentation. I know maybe Adam would have liked me to make a PowerPoint presentation, but please bear with me. I'll be reading out my presentation, if you don't mind. So, dear participants, ladies and gentlemen, my dear students, faculty members, if they are joining here, all the health practitioners, let me say that the timing of this summit could not have been more opportune than now, when the world is embroiled in the fight against COVID-19 pandemic. The theme of this summit is equally important, for it places women leadership on the twilight of healthcare development and empowerment. As a woman leader myself, I am heartened by the fact that our discussion today is an attempt to explore that nexus, the nexus between healthcare, women leadership, and health development. I am not, of course, an health expert or even health practitioner, but I thought it was important to join you and share my perspective on this important theme, especially with regard to women leadership. My students, including Caitlin, they know how passionate I am on issues of women and leadership. I really appreciated that you saw the need to be able to devote a session to discuss on the women's role. Let me start by sharing with you some glaring statistics with regard to the women in the health sector. The United Nations has estimated that worldwide, 985 million women are aged 50 and over. This was 2020 statistics. In 2050, the figure is estimated to rise to 1.65 billion. And it is estimated that the female population by now is 3.8 billion, and the estimate for 2050 is 4.8 billion. So despite this very telling reality, more than 25 years, especially after the Beijing conference and declaration on women empowerment, on gender equality is still important and neglected in the public health and many areas of healthcare. Despite that, women have naturally stood at the pinnacle of leadership, especially in the improvement of the health of their families and communities from time immemorial. They have continued to play a critical role today in all institutions of power in our societies, namely at the family level, at the community level, the healthcare systems and the states. That's where you find women. So the statistics have it that women make up nearly, of course, 70% of the world's 30 million healthcare workers. But when it comes to taking the lead in the delivery of healthcare, they are systematically left to take the back seat. We have seen it in this current COVID-19 pandemic and the responses. Unfortunately, there were very few, if any, discussions of this caliber to try to interrogate the impediments that they are facing in their discharge of that noble duty. The women have continued to face discrimination and denied the opportunity in many ways that would have otherwise enabled them to achieve their full potential. As the world endeavor to achieve universal health coverage in this century, given the role that women have been playing in community health development, their leadership in this crusade is an inevitability if we are to record, it's inevitable if we are to record any remarkable success. In other words, let me say that the Sustainable Development Goals, one of the development goals that seeks to ensure health, lives, and promote well-being for all ages, as to go hand in glove with the SDG 5, that this is Sustainable Development Goal 5, that seeks to achieve gender equality and empowerment of all women and girls. Distinguished participants, dear students, members, in the face of the historical gender-based inequities that denied women access to quality education opportunities, nutrition, healthcare services, and what have you. It is unnatural that you look at the current statistics, you will be hardly amazed by the fact that political leadership of women, especially in the field of global health, is glaringly minimal. But fortunately, we have seen in several African countries, the women have taken a lead as ministers of the Ministry of Health in the health sector, including Tanzania, in Egypt, in Zambia. They came to light following this pandemic. We also have an issue to deal with young girls and the women who have continued to die due to complications from pregnancy and childbirth, as well as other women-specific diseases like breast cancer. I was saddened by one of my staff member, who lost his wife as she was giving birth because of something that could have been prevented. So my staff lost the wife, lost the baby. For people in the United States, they will not even understand this. But that happens every day in our health systems. It is my firm conviction that addressing gender disparity in global health leadership is the crux of the problem, and that's where we have to focus our attention if we are really serious about healthcare development in general. It is heartening to read the statistics from the Interparliamentary Union, which was compiled in October 2019, which showed positive relationship between women leadership and positive health indexes. This is the direction that our societies and countries must be heading to, for the statistics supports this reorientation. In our neighboring country, Rwanda, for instance, representation of women in parliament has reached more than 60%. It is actually at 61.3%, and they have had positive health indexes. They have recorded considerable progress in reducing maternal mortality, and in 2012, they were on track to achieve targets on reducing infant and maternal mortality. So dear friends, my dear students, distinguished participants, despite these very informing statistics, the cultural norms, the expectations, and the systemic biases have continued to confine women to the backseat role in the health delivery. Many women on the front line of health delivery continue to have their work either unrecognized or completely unpaid. In the campaign to empower women in the health delivery system, Johnson & Johnson estimated that women contribute about $3 trillion worth of work to the global health economy every year, making up about 5% of the world's GDP. What is unfortunate is that nearly half of this very important life-saving work is either unpaid or unrecognized. It is therefore incumbent upon us, especially our upcoming students, to have this trend, see how this trend can be reversed, either through advocacy or through research or various interventions. I'm sure we can record considerable success in our drive to achieve universal health care if we all play our part. I must, however, point out at this juncture that the picture is not, of course, completely bleak. And Kathleen, I want to emphasize this. I don't want anyone to leave here thinking that the situation is so bleak. No, there always are silver linings. We have seen remarkable strides that have been recorded under the normative global vision, where, of course, the sustainable development goals were drawn. Of course, a lot of work needs to be done to reach the goals we have set for ourselves, the demographic, the geographic, and epidemiological change that we are facing, where the burden of diseases felt by women is also changing. Our response to dealing with health issues too must change, and women ought to be more involved than it is currently the case. Governance as the core pillar of the health system and greater parity and gender responsive, the transformative leadership are essential in our efforts to strengthen health system and meet the gender and health related sustainable development goals under number 9 and 10. So dear students, dear participants, let me say the onset of COVID-19 is to me an impediment that threatens to unravel even the little achievement we have so far recorded in this regard. It continues to exacerbate the existing inequalities and place a disproportionate burden on women, including in healthcare settings. Women health workers are faced with increased workloads, a gender pay gap, shortages of personal protective equipment that fits them, and harassment and violence as they respond to the pandemic on the front lines. We have seen how even gender-based violence has increased during this time of the pandemic, of course, blamed on the lockdowns. The pandemic has also been a setback to the advancement and progress of the women agenda. Many women find themselves in an impossible situation of having to assume multiple care responsibilities at home and outside the household. It is concerning that the impact that the pandemic has had on the mental health, I want to emphasize there's been wide-ranging mental health, of course, among not only women, but of course among populations, but more affected are the women in the health workforce, and of course, and beyond, which is quite compounding. While in the fight against this pandemic, women continue to deliver global health, many continue to be designers and leaders of global health. I don't have the exact statistics, but from the past experience, I believe even in the fight against this pandemic, women remain largely absent from the global decision-making in COVID-19 response. If we are vigilant enough, the enduring after effect of this pandemic will not be only felt on the health system themselves, but also on decimating the hard-won successes in the aspects of gender mainstreaming that we have so far achieved. As we marked last year, the 50th anniversary of this, of the Sustainable Development Goals on gender equality, we see that the cornerstone is not only for improvement of women's health in particular, but also global health in general. I want to exhort that while the fight against this pandemic is a formidable one, we should not relent and lose focus on gender-related development goals, or else we risk the successes we have painstakingly recorded in this aspect for so long. However, in closing, I wish to urge all of us to remain watchful of the serious concerns that have arisen on the current global gender backlash, which is controlled by various powerful conservative, populist, and religiously dominated governments. We are witnessing the emergence of anti-gender campaigners who have even gone so far as trying to overturn existing laws on basic human rights. But by improving leading positions of women in healthcare and supporting their unique values, all themes connected with this summit will be put higher in our agenda, but also as we try to speed up the realizations of the development goals. Coming from Tanzania, I want just to share with you that we have a new president, a woman president, female president. It's the first time we have had a woman president in the history of Tanzania. And we have seen how women leaders lead differently. And I'm part of that team of the new leadership. I can't say we have a feminist foreign policy or feminist policy as in other Nordic countries, but you can see that is the path we are leading to ensure that the women are at the table, the women are part of the decision-making process, especially with regard to the well-being of their families, of the communities, of the nation, and of course, at the global level, we are actively engaged, and this is the very reason that I decided to participate in this George Washington organized health summit. Although I'm not, again, I'll soon at the end of this maybe month, I'll be quitting as a professor, as a lecturer on women in leadership in Africa. So thanks again for your invitation and for your kind attention. I want to thank you again and again, and I would like also to call on everyone to give a big hand of applause to the organizers of this summit, Adam and Caitlin. I'm proud of you. Thank you very much.
Thank you so much, Your Excellency. I would like to ask a question. So, since you have been in Tanzania for a while, have you found any differences between like healthcare between the two countries in the context of women's leadership?
Yes, thank you for that question. As I said, for Tanzania, we are going through a very transformative leadership period, which I never experienced before. I see a lot of differences in terms of the focus, the issues that are preoccupying the current leadership. It is about socio-economic transformation, but then you have issues that impact, especially on our communities, and the women in particular are given more prominence, more importance, and are the priorities. Issues of healthcare, issues of maternal mortality, issues, of course, of women empowerment, issues of access to water and sanitation, because that's where women are, issues of agriculture, development, and empowering women to participate and produce that products that would sustain not only the family, but the entire community. So I can see a shift or a reverse of priorities that is focusing on the well-being and the livelihood of the population, and of course also the women in particular. So this is what I see as different. It's been now less than 6 months since this new leadership has taken over, but I'm very optimistic and I'm very hopeful that we'll see a big transformation under this new leadership.
Thank you. Does anyone have any other questions?
Oh, after you, Caitlin.
Oh, no, don't worry. You can go, Adam.
I was just going to ask, in terms of Tanzanian healthcare development and I guess women's leadership within the field, how do you feel the next steps need to be in terms of increasing the educational outcomes for women within Tanzania? Because at least when I visited last year, my experience was that there's a bit of a disparity between men and women. How can we increase the number of women doctors, women healthcare leaders although right now it is very good that they are leading the public health process in Tanzania now. How can this be improved?
Yeah, of course, I do want to paint a very rosy picture that all is well. We still have this big gap in terms of the education for girls and boys. Also you see a big gap in terms of the girls taking up subjects that have to do with science, technology, and maths. And if you don't take those subjects, then it's very difficult to make it to being a doctor. So there's a gap. Of course, the government policy is to trying as much as possible to establish even special dedicated schools to science and technology, but also giving more priority and preferences to girls' education. It's an enormous challenge in the sense that we still have, of course, those traditions and norms that pull down the girls. Girls not given priority to go to school, but then even those who go to school, then they are faced with these social challenges of early marriages, of pregnancies, and most of them, of course, they leave schools. So we still have those challenges. But at the level of the government policy is really to promote, especially the girls' education. It is challenging, but I think we are on the right path.
Yes, absolutely. It is wonderful. Thank you so much. Are there any other questions? If it's okay, Your Excellency, that we go till 10:50. I know that you might be busy now. If you have to go now, we understand. But if you have time to answer questions till around 10:50, that'll give us some time for the next panel to come in at around 11.
Okay, thank you. I can stay around a bit if there is more questions, or if there's anyone else who is going to speak. I do want to consume all the time so that I could leave time for some questions, a discussion.
That is wonderful. Thank you. Are there any other questions?
If it's okay if I ask another question. Your Excellency, I'm curious to know how healthcare plays into your role as the Minister of Foreign Affairs, and if you had dealt with healthcare policy and development in the past in your roles.
Yes, the position I've held, it's always I get to play all different roles as being in the foreign service, because when you are in the foreign service, first and foremost, the global agenda, whether it is on climate change, whether it's on health, whether it's on poverty alleviation, in all aspects, peace and security, you get involved. And I was the chief advisor to my president, so it was like, it was all multidimensional aspects that I was covering, including this issue of health. Because as you have witnessed during this COVID-19 pandemic, you find that all countries are affected. And all countries are all attempting to have a coordinated approach, which is coordinated, of course, through the World Health Organization. And once you get the international organization, international community involved, then as the Minister of Foreign Affairs, you get involved to know what is going on, what is being coordinated, what is there for your country, and how you can partner with other countries. For example, in this issue of vaccines, I don't know if you have heard of this COVAX. The COVAX is like a facility, a world facility that has been created through which countries that cannot afford the vaccine on their own, then they can be able to access it through this facility called COVAX. So then, as the foreign minister, of course, I'm involved to get, of course, Tanzania be part of the COVAX, but also see how we can work with those countries, especially those who are contributing to this facility, to get Tanzania also, when it is ready to be able to access these vaccines. So you find yourself involved. Now we are preparing for COP26. This is a conference on climate change and environment. So you get involved, although it has politically, maybe you can find this, wow, what do you have to do with issues of environment? So this is, it's like a world agenda, and therefore you become like a world foreign affairs actor. So you cover a number of issues. And as I said, at the moment, of course, everything is revolving around this health crisis. So on our part is to see Tanzania to participate, is part of the world, is not an island. So we have to work with everyone around the world in trying to put, of course, I don't know when this will end, but just gets to have access to these vaccines. So this is why I'm involved with these issues of health, because that is the issue of the day. And as foreign minister, you cannot say, oh, this is not my issue. It is, it is. We engage countries of the world and its international organizations and the peoples of the world too.
Thank you so much.
Thank you, you're welcome. So if I may also ask a question, Adam,
Yeah.
what do you see as the outcome of this health summit? Because I see it's very important. What will be the outcome like?
Right. So it's a part of a three-part contingency plan. First, the health summit is to raise awareness for different educational, different factors in the health, sexual health, mental health, medical innovation, healthcare administration, and business. So we really want to give students a large view of what the healthcare sector is like. So that's number one, it's about education. The second is that, just so you know, the Health Summit is hosted by a coalition of different organizations, including the American Medical Physiology Club, ISAC, just to name a few. And we're working together to create opportunities for our organization's student members to engage in health-related different projects on campus and outside of campus in a more coordinated fashion. Together, we represent more than 2,500 students at the university. So we have a really large collective action potential where we could really improve healthcare through these large projects, which we'll actually be discussing in a larger conference this coming fall during the first week. So it's about collective action, it's about education. And then third, our coalition runs this thing called the GW Health and Education Equity Library, which essentially we've gathered many different pre-professional books and different supplies, such as learning how to do CPR, AED training, MCAT, LSAT. These are all American pre-professional books that help you become lawyer, doctor, all in the context of helping students to achieve their professional goals. So it's about professional development, advocacy, and also education. So that is the main three goals of what we're trying to do today and in the future.
Okay, great. No, those are very important goals, and I hope you'll be sharing the link, of these conversations with the rest of the students, because I'm sure some very important issues would come up in this summit.
Mm-hmm. Xavier Fields has a question, if it's okay if she asks.
All right.
Hi, thank you so much for coming in and speaking with us. I'm so honored to have been able to hear from you today. I was just wondering, how do you think students going into healthcare or medicine can contribute into women's leadership?
Can you say again? I'm sorry, I missed you say the women.
How do you think students going into healthcare or medicine can contribute to women's leadership?
Yes, of course, the students who get into the medicine, I'm sure it's a mix of men and women, boys and girls. So for sure, the doctors, I see that the doctors, once, of course, they graduate, they can always, being in the field, they can always promote the women, especially those who are at the middle level, low level of healthcare, and recognize that the important role that they play, these women who are skilled, they may not be very highly educated, but then those who have qualified, have doctors, to be able to recognize them and to be able to use their skills as very important input in your, as a doctor, I was saying you need to promote these women. Some have been there for years, they have experience. Some have been midwives, traditional midwives. So I would see that how the best way is to recognize especially these very highly skilled women, but who never had opportunity to attend the high level education of it. So this is what I would see as a big contribution in uplifting these women who sacrifice, they do a lot, but they go unnoticed. Sometimes, of course, they're underpaid. So if you are to graduate and then get into the field, I would really recommend that recognize those women who would not have the opportunity to reach your level, but they have important role to play.
Thank you so much, Your Excellency. It was such an honor to speak with you today and having you here as our keynote speaker and really introducing what healthcare is all about, why we are pursuing it, not in just the context of healthcare alone, but also in terms of women's leadership and how we can make a more equal society through healthcare. It is such an amazing thing, and thank you for your time.
Thank you for your invitation, and I wish you all the best for the remaining part of your program. And I look forward to keeping in touch with you. Feel free anytime. If there are issues you want to share, I can also share. If you need anything, information from Tanzania, please don't hesitate. Let's keep in touch.
Of course. Thank you so much.
Safe and well. Thank you so much.
Thank you. We'll love having you again sometime soon.
Thank you.
Thank you, Your Excellency.
Bye-bye.
So now for the rest of the remaining of the session, we're going to be taking a break until around 11 o'clock when our next panel will be beginning. So you guys can get up, take a stretch, and we'll be joining back with you at 11 o'clock. Thank you so much. Hello, Ms. Mills. Thank you so much for coming in. We are currently during our break. We just spoke with the Tanzanian Minister of Foreign Affairs, and we'll be beginning at 11 o'clock.
Yeah, I'll be here. I wanted to listen in some, so I'll be here and I'll be ready for my panel.
Sounds good. Thank you so much.
Okay, sure. Looking forward to it. So I'll go on mute so people aren't hearing me.
Sure.
Okay, talk soon. Looks like a lot of folks. That's great.
Yeah, thank you.
Okay.
For those that just attended our last portion of the event, what did you guys think of the last speaker, Her Excellency Mulamula? Caitlin, what did you think of our last portion?
Well, she was my professor this past semester, and it was honestly, I'm just really happy I got to see her again. Like after she accepted the Minister of Foreign Affairs role, it's been a lot harder to be in contact with her. But like having her talk about women's leadership in context of health was really, really interesting. Um, Especially with COVID going on, that's like a really big thing, and having like such a higher up role in the government provides like a really unique perspective. So I'm really glad that we were able to hear about that.
Yeah, absolutely. It was so enlightening what she said during her conversation. I think it was really awesome that she was actually in the Congress of the Tanzanian government when she came and spoke with us. I thought that was really amazing to be able to she was really in the middle of it all. She was during a meeting for Congress and then at the time came and spoke with us. So that was really delightful. Are there any other thoughts from the other participants? Adia, what did you think of the event so far?
I really enjoyed listening to her. I thought it was pretty insightful, and I'm happy to be a part of it.
Would anyone else like to share some thoughts during this break period about what they felt about the last point of discussion? Hello, Dr. Levkoff. How are you?
I'm doing well. Thank you, Adam. Thanks for having me.
Thank you so much for attending. Really excited to hear you and Dr. Rodriguez Diaz and everyone talk very soon.
Wonderful. I'll just sit here quietly until then.
That's good. Yeah, we're currently in a break. We'll be beginning again at 11 o'clock for the sexual mental health panel. Ms. Mills, I just wanted to clarify really quick that we'll be having your panel at 12 p.m.
Correct. Yep. I just wanted to listen in on some of the summit.
Sounds good. Thank you so much.
Sure.
Hello, Dr. Semnau. Thank you so much for coming in now. Right now we're in a transitionary break period. We'll be joining on at 11 o'clock. So yeah.
Okay, great.
Hello, Dr. Rodriguez Diaz. Right now, we're currently in our break period. We'll be joining back on at 11 a.m. In the meantime, we'll just be here with our cameras off. But thank you for coming early.
Good morning. Thank you for inviting me.
So before we go into the next session at 11 a.m., I just want to give a big thank you to Dean Lynn Goldman and also Her Excellency Liberata Mulamula for coming at our first session and really giving us a highlight of, first off, introducing the event and also giving us a better understanding of what women's health and leadership is like. With that said, I will let our next moderators go ahead and introduce our next three panelists. So if Kayla, Shawn, and Pat, you guys are ready to introduce the next session, we're ready to go.
Yeah, for sure. Okay. Hello, everyone, and welcome to our panel on sexual and mental health. My name is Patrick Talana of the GW Student Association and the College Diabetes Network.
Hello, everyone. My name is Kayla Brock, and I'm the co-president representing GW Leading Women of Tomorrow.
Hi, I'm Shawn of Timmy Global Health.
We have the pleasure of introducing Dr. Carlos Rodriguez Diaz, Dr. Logan Lefkoff, and Dr. Charles Semnau for our mental and sexual health panel.
Dr. Carlos Rodriguez Diaz is the Director of Community-Oriented Primary Care within the Department of Prevention and Community Health at the Milken Institute of Public Health. He is also a community health scientist who is currently studying health and racial disparities during the COVID-19 pandemic. Previously, he has led in several research projects addressing health inequities among vulnerable populations. Dr. Rodriguez Diaz's research has been featured in well-known national and international media sources, such as the Washington Post, The Hill, The Guardian, among other well-known media sources. Dr. Logan Lefkoff is an internationally recognized sexuality and relationship educator who uses her platform to speak about sexuality, parenting, and Judaism. She spoke on multiple television shows such as Good Morning America, The Today Show, The Rachel Ray Show, and many more. She has numerous trusted publications which continue to cultivate healthy and positive messages about sexuality and relationships.
I am pleased to introduce Dr. Charles Semnau. Dr. Semnau is an associate professor and the assistant director for medical student education at the George Washington University School of Medicine and Health Sciences. Dr. Semnau has received multiple honors and awards, including election to Phi Beta Kappa, recipient of the American Medical Foundation's Leadership Development Award, and the 1999 Exemplary Substance Abuse Prevention Program Award presented on Capitol Hill by the U.S. Department of Health and Human Services.
Thank you for taking the time to meet with us. Kayla, Patrick, and I prepared a few questions to ask you guys. So first, what aspects do you believe play a role in fostering a healthy sexual education?
Good morning. I'll be happy to start the conversation. First of all, thank you for organizing this event and for inviting me to be part of this panel. So first of all, I appreciate the importance you are giving to sexual health by highlighting it as part of this summit. I would say that the evidence of the lack of sexuality education is that even when we discuss health, we does not always include sexual health as an essential component of our well-being. And that happens not only in families, in our formal education, but also in the formal education of many people who provide services, including healthcare providers. So certainly we have, the best we can do to provide sexuality education is first recognizing that there is a need, and second, providing sexuality education that is appropriate to to age, but also across the lifespan. Because sexuality education is like, for many physicians, like the CMEs, we need to continue learning and having develop abilities, not only to have the knowledge about sexuality, but also to translate that into our human interactions. For those of us in the healthcare field, we need to feel comfortable about our own sexuality and talking about sex. So that's the only way we can improve healthcare encounters and in fact address the needs of multiple populations.
I think that is such a great place to start. As someone who works in the trenches of education with young people, I think that the real challenge we have is this idea, particularly in this country. I mean, certainly other places too, but I'll just focus on this one for 1 second, that we have this very polarized take at how important sexuality even is, right? I mean, it is either exploitative or we are so puritanical and sex negative, and that's not where most of us live or express ourselves. And I think that we get very tripped up in this idea that sexuality is something that we all have from birth to death, because we hear that word sexuality and we think we're talking about sex and how to have sex and what is sex, when actually we're just giving people across all lifespans and demographics the tools in which to best express themselves, develop a sense of empowerment and confidence, and decide for themselves how to interact with the world and the people around them. And of course, pleasure is a part of that, which makes this conversation complicated. I mean, certainly not for the people sitting here on this panel, but possibly for others.
Great, I'll just add a little bit. It's thrilling to be here with such a great group of panelists and other interested folks. You know, obviously I agree 100%. In my area where I focus more on problematic sexual behaviors, it's very easy to get into a trap of becoming very sex negative and viewing sex as a pathological process. And that's something that really plagues our field and plagues the physician world or health provider world, because physicians, we look for problems, right? That's what physicians are trained to do, look for problems, as opposed to promote health and well-being. So one of the areas that I've developed curriculum at our medical school on is on sex and disability and chronic illness, recognizing that individuals who may be paralyzed or have chronic pain still have sexual lives. And, you know, we do a terrible job for folks who are abled. What about for folks who are disabled? Sex in the autism spectrum and sex with individuals who have mental health problems. These are tremendous areas where, again, I think we fail those who need us most. And then even sex among sex offenders. How do individuals who've been convicted of a sex offense restore healthy sexuality? From the criminal justice side, it's sort of like once you get a sex offense, that's it. You know, you're off the internet, there's no masturbation, there's no dating, you're done. Again, that is probably only serving to further stigmatize, shame, and fuel problems in this area. So, you know, I look at not just across age and orientation and identity, but I also look across populations, special populations that may need this education, advocacy, and awareness most.
Wow, thank you so much for those responses. I really appreciate it. I found it very interesting, just the way you guys were able to work off each other. So my second question is, what is the current state of addressing topics on mental health within the education system? And do you have any suggestions on how to address these topics more effectively?
Look, I'll take that. We'll start backwards. I'll take that one first as a psychiatrist. You know, I can't really comment about education in our schools, K through 12. So I'll let other panelists who perhaps know more. What I can talk about is education at the medical school and our physician level. And quite frankly, it's better, but it's still not great. For example, the head of the National Institute of Drug Abuse said that the #1 way to promote addiction as a disease model is to actually get physicians to believe it. And right now, many physicians don't believe it. They believe that addiction is a problem with will and choice or moral deficit. So we have a lot of work to do. I would say training those who are testifying in front of Congress, who are testifying in front of the Board of Education about mental health. We have to make sure that those who practice it are working to destigmatize and provide accurate information. And I would say medical schools are doing a better job, but we still have a long way to go.
So first of all, I should have said earlier, thank you for having me. That was very rude of me. I apologize. So thank you for having me here. You know, the lens in which I see the world in my field is really strictly through the world of sexuality education. I'm an educator. That's the umbrella that I live and operate under. I think that when we talk about education, and certainly I can talk about K-12 education, is that there is no universal protocol for dealing with any of these things in schools, which makes things so inequitable across all demographics, because whether it's a public school and it's a school board making decisions, whether it's an independent school with a particular, you know, religious or educational perspective, there's just nothing universal to it, which means that we're sending young people off into the world with very different skill sets, very different understandings of who they are, and just very different set of tools with which how to navigate the world. And I mean, we certainly see it in terms of the pretty detestable history around sex ed we've had in this country. The fact that we still have, you know, in the teens, states that don't require medically accurate sexuality education, which, I mean, if we just think about that for a second, how completely unconscionable that is. So because we have no universal standards, or I should say we have lots of organizations that have put out standards, the problem is that there's no way to make sure that everyone is following it currently.
And from a public health perspective, I would say that the main barrier that we have is stigma. We have stigmatized mental issues, and the same way it's in a similar way that we have stigmatized sexuality. And that makes it very difficult to address, because we are grounding the efforts often on values that are inconsistent with the work that we need to do to promote health. I believe that there is a lot of work that we need to do. And when I speak of we, is those of us interested in the health field, because we need better education for ourselves. We need to advocate for better education at different levels. And we need to integrate the knowledge, skills to remove the stigma that is a barrier for education, prevention, and therefore to access to care as well.
Thank you so much for your responses. I really appreciate the way you guys talked about the education system and just answer the question how it was asked. I mean, I went to a Catholic school all my life. We didn't really learn much about sex education, so it was interesting to hear from your guys' perspective. I'm gonna introduce my twin, Patrick, to ask the next two questions.
Yeah, hey guys. You guys' answers are actually perfect because it perfectly segues into the next question, which talks about inequalities in sexual education. So research shows that STDs are more frequent among certain racial or ethnic minority groups. This could be due to a multitude of factors, many having to do with the lack of resources made available. What are some ways you suggest we address these health inequalities in these communities?
I can start with that one. Certainly, there are some disparities that have been documented in the distribution of STIs, including HIV, among minoritized populations, including racial and ethnic minorities. However, I think it's very important to set clear that there is nothing that is inherently personal or characteristic of those minoritized individuals that increase their risks. We socially increase the risks of these populations. These populations are also overrepresented among those who have less access to certain resources, from poverty, unstable housing, less quality in their education, and so many others. From a public health perspective, we refer to those as the social determinants of health, because we know that there's social and structural factors that cause that minoritized populations have environments and contexts in which there is an increased risk for STI, HIV, and others. And in this context, we're talking about STIs and sexuality related conditions, but it's also true for many other health issues. So what we need to do first is understand that there are structures of powers that are socially defined that we need to change. We have systems that are perpetuating inequities. So yes, we need to provide sexuality education that is consistent to the population needs, but that's not enough. If we don't redistribute wealth, if we don't improve our healthcare system, if we don't improve our education system, we will just continue to have we will not be addressing the root causes of these disparities.
I would just add that oftentimes when my students bring up the issues of the why, so the inequities among just sexual health outcomes among populations, my comment is always, we have a tendency to blame a population instead of recognizing that we are actually responsible for all of those outcomes. We create those situations for people where they can't access information and services, where their healthcare providers come to the table with certain particular values, so don't provide certain information or services or tools. We perpetuate shame and stigma. Right? We see it in our cultures across the board all of the time. So I'm so appreciative that you just said that, because we are responsible for this. It's never a population's fault that they have certain health outcomes, but certainly sexual health outcomes.
I don't think I have much more to add to that. Again, I think about with inequities, what are some of the ways that we can work on that? And, I think the question in and of itself, saying that there's multiple factors related to this, is sort of the answer. We've got to approach this at all levels, whether it be through K through 12 education, access, and unfortunately, not to get too political, but when there are agendas to get rid of Planned Parenthood, which serves maybe one agenda item, it then causes a whole cascade of effects in terms of what that organizations and those clinics do in terms of offering access to populations that now are not going to have access. So there's a variety of things. So that means educating at the legislative area. And then, you know, again, I'll keep on coming back to our doctors over and over again. Surveys of physicians, of patients say they don't feel that they trust talking to their doctor. They want to talk to their doctor. Their doctor doesn't open the window to that conversation. And of course, you know, in the managed care era, when you have only 15 minutes or 10 minutes with a doctor, you know, what falls to the side, things that are more difficult to talk about, those conversations. So we've got to think about this from a public health, provider, systems, political education perspective. And it is multifactorial, as the question suggests.
I would just add that I've taught many, I've taught grand rounds, I've taught med school students about child and adolescent sexuality. And often the question that I'm asked first is that, you know, can we please hear about the pathological paradigm of child and adolescent sexuality? And my comment is no, because that's the wrong paradigm to use. So much of what a young person experiences throughout their lives is very typical. But when we reframe it as pathology, I mean, we're never going to get the positive health outcomes we want.
Thank you so much for those responses. They're all really awesome. I really liked how you said we all got to hold each other accountable, and you know that's how these inequalities exist. So the next question I have is from a parent's perspective. So as a parent, how might one create spaces for your child to explore their gender identities and expressions?
So I guess I shall start with that one. So, I mean, admittedly, I have a 12-year-old and a 16-year-old, and there is nothing that I share with groups that I talk to that I don't practice in my own home. So I think that the first thing is we need to get rid of the word awkward as if it is a inherently negative word. One of the things that I've noticed so much in my work in the last 5 years across all groups is this fear of having conversations and being perceived as awkward, as if awkward and vulnerable is an inherently bad thing. And look, I can't attribute it to one thing, though I would say that probably living in the internet and being able to manipulate and filter and echo chamber your life probably contributes to some of that fear of vulnerability. But I think we have to get rid of that word awkward and recognize that that's a very important word when we talk about sex and identity and bodies and feelings. I think that in you know, if you are raising children, and I would use that word as broadly as possible, in any capacity, whether it's a parent, guardian, grandparent, foster parent, adoptive parent, aunts, uncles, etc. I think the first question we ask ourselves, and the first question I ask my groups to ask is, think about your own upbringing and think about how your life might have been different if the information you received about sex and sexuality and gender had been different. Right? To really sit with that for a second and think about how those messages played out in your life is really the impetus for changing that model if it didn't work for you. And I think it's about recognizing that these binaries that we've been, you know, that have been shoved down our throat for so many years have really actually never represented the bulk of anyone, and that it's okay to challenge them. But of course, I would say before I stop rambling, it's not just enough to give young people the visuals and the experience to explore everything beyond binaries, but also give young people the tools and the words and the confidence to have a voice to respond when someone does challenge that in their lives, because they certainly do, and they will. My son has had long hair since the time he grew out his hair. His favorite color has always been hot pink, and we spent the bulk of his toddler years coming up with language for saying, yep, yes, I know, I'm a boy, I have long hair, and I like pink, right? But if we don't give young people the tools to do that, then they sit and internalize it and feel badly, and that's the last thing we want.
I'll jump in real quick. I don't have kids, so I really can't comment on parenting, although, you know, growing up as a gay male, I can certainly comment on what it was like to, you know, have parents and what information I did receive or didn't receive. So, you know, I would echo that, you know, it really, I think, again, sometimes we will make generalizations on families, and, you know, there are accepting conservative families, there are intolerant liberal families, you know, so it doesn't come to any, you know, I think you got to view individually families as opposed to making generalizations. And so as I work with folks, it's really important that I don't bring that bias into my conversation, because if I automatically assume that a family is unaccepting just because of their identity, then I may miss the mark. So that's one really important thing. But the second thing I think is, you know, what's interesting today and the folks I work with is most kids, you know, they know the stuff. They're getting it from the internet. And the question is, do you want them to get the right information or the wrong information? And are you going to serve as a guide to your child, or are you going to serve as a barrier to your child? So, you know, before, you know, we used to have to look in these little books like Our Bodies, Our Lives. And, you know, I'm sure our panelists will crack, you know, that's probably an old school stuff. And, you know, sneak through the pages, maybe at the public library, which when the library used to have books, you know, and, but now with the internet, pretty much you can learn anything that you want, good or bad. Pornography exposure happens very early on for many folks. So as a parent, I think recognizing the role of, hey, your kid's going to learn about this. So rather than fight it, let's have these healthy, tough conversations.
Yeah, and briefly, I would add that I'm not a parent, but I feel that I'm part of a community, or several communities that support many kids. And I often, well, and I, similar to what Dr. Semnau shared, I believe that my experience have also influenced what I do and the ways I like to deconstruct my own experience to understand what was healthy for me, and how that has transformed myself and the way I approach my work. And a question that I get very often is, well, how is it to grew up gay in the Caribbean? I grew up in Puerto Rico in a very Latino Caribbean environment. And I like sharing my experience because I think it was unique. We all have unique experiences, but referencing to what my colleagues have said, I got some strength from the experiences that I had. It was unique, and it's definitely not the average experience that I have studied for other gay men in Puerto Rico. But I use those experiences to facilitate conversations, to share the different opportunities that we have to be supportive as members of a community. So it's not only the learning experiences that we can provide for kids is not limited to what the parents can do. It's also what the environments that we create in the school, in our communities, in our policies. There is so much work being done right now to hurt kids around the United States because they don't fit the binomial understanding that we have about gender. So we can advocate for changes that really make it easier and consistent with what a healthy society is for everybody.
Thank you so much. That was all so awesome. I really appreciate you guys talking about your personal lives as well. I do believe that, you know, sexual identity is very subjective and how you find that. So it was a pleasure talking to you all. I'm gonna let Kayla handle the next few questions. So.
Hi, thank you so much. So this question we started to address, Dr. Levkoff, he started to address part of it. So I apologize for any overlap, but I do think it's an important question to ask. Conversations surrounding sexual health and education are often regarded as uncomfortable at best. Do you have any recommendations on how to effectively communicate about sex and ways to embrace uncomfort rather than shun it?
Sorry, I almost remuted myself. Yeah, well, clearly it's a good question because I deal with that all of the time. I don't ever want us to be afraid of discomfort or vulnerability. It's a really important feeling, and there's so much resilience and confidence and skill development that we build upon by having uncomfortable conversations. And just as an aside, I mean, look, I have to be honest, especially like raising adolescents and working with hundreds of adolescents a week. It's one of the things that I find I worry about most about coming out of a pandemic, that so many of my young students aren't developing those intimacy related communication skills and vulnerability and flirting and reading body language and all of the things that we really need, not just as young people, but certainly also as adults. I think that sometimes we are made, sorry. In the beginning, we often use the term age appropriateness. And I want to say that as someone who teaches young people about sex, I find that, for lack of a better term, that model, that phrase, age appropriateness, becomes really paralyzing for a lot of people, because it's actually used, I believe, as a means of preventing conversations from taking place instead of encouraging conversations. So oftentimes when I work with adults, they'll say, but what's age appropriate? And my answer is always, if a young person has a question or a concern, they deserve an answer, right? It's not so much about age. And certainly, as we know, that there are young people capable of getting really sophisticated information about sex and sexuality, and some adults that do a terrible job processing that information. So this idea that there is one perfect moment to have conversations, I think actually really hurts us in the end. And so part of getting past discomfort is making sure that everyone realizes that the magic happens when you get out of your comfort zone. And that's the only way, in my humble opinion, to make real progress in this area, that we have to stop relying on those old messages and do what we feel is instinctively right for our relationships, whatever those relationships may be.
So I'll focus my answer on what I do the most, that is collaborating the training of public health and healthcare providers. And let me tell you, for many of us, it's very uncomfortable to talk about sex. So, and public health and medical schools are not doing great in incorporating sexuality education as part of their curricula. Just so you know, I think the latest research with medical schools is that it's just a few hours of sexuality education that is mandatory in 4 years of medical education. That might be a little different in some specialties, but just a little. And as our colleague shared, is very focused on the pathology, on identifying the problem and trying to fix it biomedically most of the time. And in public health, we also need to talk about sex because it's part of population's health. And often in primary healthcare encounters, those encounters could be very awkward. And if we don't talk about sex, or if the provider is not comfortable talking about sex, further, if we don't talk about sex, we might miss many opportunities to provide the care or the screening that some patients may need. So at my end, what I've been trying to advocate and do is to incorporate more sexuality education, not only as dedicated time of the training, but as integrated to other disciplines. For example, if we are training on bedside manners and conducting a good screening, we should provide the trainees with experiences where they can ask about sex, and from knowing how to ask what to come up with solutions and recommendations for their patients. And in public health, we don't need to wait until taking epidemiology of infectious diseases to start talking about sex. We should do that in Public Health 101. and the lack of diversity that we have in research simply because we don't ask in basic surveillance surveys questions about the gender identity or sexual orientation of individuals. So there's a lot of work to do, but we are doing it. And let me tell you, I am also very hopeful that younger generations are going to do better than what we've seen and what we are doing. I think we are creating contexts in which diversity at all levels is being perceived in such a different way that many of us were exposed to, and not to mention older generations. So hopefully, I am very hopeful of what the future is going to look like in terms of the interaction and the promotion of sexual health in different contexts.
Such wonderful comments, and obviously I agree with all of them. I think in my domain, particularly teaching those few hours in a medical school of sexual health education, and I've been a huge proponent of trying to expand those hours, but get a lot of pushback because, quote, other things are more important. If we think about, biologically, how important sex is, i.e. our species exists because of it. And number two, the fact that it is something we do, like we eat and we drink and we sleep and we go to the bathroom. And so one of my big pushes is to, simply talk about it. If I talk about, taking a nap, snoozing, hypersomnia, or eating or not eating, I can use any term. I can use a very highly scientific term, such as anorexia. I can say someone binged or wolfed on their food. But when I in class say that someone masturbated, or God forbid, I say they jerked off, all of a sudden, I'm written up, and everyone goes nuts. And yet this is a, fundamental thing that at least 50% of my class is probably doing almost every day. So if not, more, probably a lot more than 50%. The point is this. I think normalizing talk around sex is really important, not in an offensive way. Again, I do agree with this concept of age appropriateness. Not everybody is able to handle certain information at a certain time, and it has no bearing on the numerical number next to their name. I have folks in my class who are in their mid-20s who, quite frankly, can't handle it, compared to probably an 11-year-old who could. So that the numerical number doesn't make a sense. So we part of this in teaching how to talk about sex and helping our doctors and our health providers have those uncomfortable conversations is one, empowering them to open the door. Two, to be able to read the language and mirror what the person in front of them is feeling, not as a way to avoid it, but perhaps to tailor or to deliver a message that person can accept. I work predominantly with gay men in my clinical practice. And if I sat around saying, how often do you copulate or engage in masturbatory activity? They'd be like, who is this schmuck? Get him out of here. I got to meet my patients where they're at. And so I use the language that they use, and I talk the language, and for that we have a better relationship, an open relationship, and then we can get into stuff around things like bareback sex. For those of you who don't know, that's having sex without a condom, which of course, talking about HIV and STI prevention, if you don't know these words, you don't know the language, you're not speaking it, you're never going to get to the important issues. It's going to always say superficial. So I would say destigmatization, just like I talk about eating, sleeping, going to the bathroom, talking about sex, there should be no, again, I say should, of course, we don't live in the world of should, but in that ideal world of a magic wand, we would live in a world where there just wasn't weight to these conversations.
Thank you so much for everybody's comments on how to foster more open communication. I thought that was extremely insightful, and I really like to see how you guys had different opinions on different aspects of it. And to move to our next question, Dr. Semnau, you kind of addressed this in an earlier question, but I definitely want to explore it on a deeper level. With the explosion of the internet and growth of social media, many are receiving the bulk of their education about sexual health online. What are potential disadvantages of this, and are there advantages?
I'll kick it off and I'll try to be brief. You know, everyone goes crazy about sex online. You know, not so like, oh my gosh, this is the beginning of the end of corrupting our youth and changing society. And I'll remind folks, many won't know this because you weren't born, you know, when the car became mass produced, people thought, oh my gosh, this is the end of society because we have a moving bed. People in the back seat of the car can have sex. And now the car is going to destroy humanity because we now have a moving bed. You know, and of course, that has not been seen. I see a far lot more positives coming from the internet than negatives, particularly my transgender population and LGBTQ individuals who live in non-urban settings or even in urban settings who feel isolated. Being able to find a community of individuals online and recognize that, hey, I'm normal, there are other people like me, has been tremendous. And so, you know, I'm not, you know, look, you can be scared of the internet, scream about the internet all you want. It's here to stay and it's only going to get bigger. So again, you either ride the wave and find ways to make it helpful and educate people, or you stand there fighting a tsunami and get swept up and drowned. So I see the internet as a huge opportunity. Of course, there are other dangers. You know, I deal with online sexual offenders, so there are real dangers out there of people who misuse the internet. But again, that's an opportunity to empower our youth. And if you look at all national surveys, many kids and adolescents, the majority have been sexually propositioned online, and the majority of them tell those people to fuck off or click X and get them out of there. So our youth are learning how to deal with that online. And those are skills that can translate into other areas of life.
And I will just echo briefly, we are doing it from a public health perspective. I can tell you what we're trying to do is to occupy the space. So when younger kids look online, they get the right information, right? Currently, I am part of a team of scientists who are developing an app. So we created an app for queer kids, so they have access to queer affirming sexuality education. And then we provide a set of resources to make sure that as they grow up and they start making decisions about their sexuality, they have the right resources available. What we have learned, yes, they're going online anyway. They know how to discriminate certain level of information and what is appropriate or not when they have the right tools. They don't want their parents involved as much as we think. However, they also understand that their parents will need some resources because sometimes they feel like, oh, I'm getting more sexuality education than my parents, which in some cases is true. And they are creating a community, as my colleague mentioned. This study is a national study and it's been particularly powerful to see the stories that we get from adolescents in rural areas that are not close to places where they can see diversity portrayed in a healthy way in media or in their neighborhood. So we definitely have to occupy the space to provide sexual affirming information, not only for adolescents and young adults, but I think we can do it for everybody because the online environment is becoming the official encyclopedia, the official place where not only adolescents and young adults look for information. We know that adults across the lifespan are searching online, and we want to provide good information for everybody.
I would just offer one other take on that, which is, I mean, yes, the internet is not going away. I mean, I do my own playing on my social media platforms, including TikTok, much to the horror of my own family. But I think that in general, I am not anti any form of media. What I am very pro, though, is us giving people across the lifespan the tools to be thoughtful and to learn how to be smart consumers of media. So absolutely, you know, gather information, but also like anything else, we want to check our sources, that there are coming from reputable people, that, you know, it's based in real scientific peer-reviewed evidence, particularly if it's impacting certain decision making. So again, I think that we would say the same thing for any form of media. If someone was getting sex ed from their television, you'd say the same thing. Like, what is the purpose? Is it to educate? Is it to entertain? Like, do we need more information? So it provides us with an amazing opportunity and an amazing opportunity for information and skill development.
Thank you guys so much. I am really happy that you guys took this conversation in a more positive social media aspect or internet aspect. I think that a lot of the times in my conversations with adults, more adults than me, it is more negative than positive, and it is a much harder conversation to have to explain why it's a more beneficial resource than not, especially for me myself. I grew up in the South, so a lot of my resources have come from the internet, unfortunately for my sexual education. But I'm really happy that we were able to have this kind of discussion. And on that note, I just wanted to open up the floor for questions from the audience. If you guys have any, so I'll take a couple seconds to stop talking and let you guys start raising your hands if you are interested in asking our moderators our speakers any questions.
Oh, I do have one question, if that's okay. So I guess I would like to understand what your guys' perspective on how COVID-19 has hindered sexual education, especially, you know, with everybody being in lockdown. How do you think that COVID has impacted it during this time, and how do you think it's going to change over the course of the coming years?
So I will tell you that in the last year, so I work as an independent contractor. So I am a traveling sexuality educator, and typically in an average week in a typical year, not in a pandemic grounded year, I can teach 15 classes a week at 4 to 5 different schools, all different age groups, you know, kids who have certain disabilities, single sex or gender schools, religious, secular, the works. Up until last week, I was maybe teaching 1 class a week. Last week it changed now that things are opening up a little bit more. So what I think is really challenging is that I have some students that will go a full, and obviously these are, you know, New York City kids who get a pretty good education in general, but some of them will have gone 2 years without any information about health, sexuality, puberty, development, anything. And it's not like all of those things that have to do with development they don't go on pause just because the world goes on pause. So I am frustrated by the lack of commitment to this education that is so critically important, you know, to developing minds and bodies. But I'm hopeful that we are starting to come out of that. That being said, as I mentioned earlier, I do have some very big concerns about the lack of sexual experimentation and intimacy skill development that our young people do not have access to or have not had access to for a while.
Thank you so much for that response.
We do have one question from the audience from the chat, which I'm not sure if you guys can see, but Rosie asks, what are your opinions on internet censorship in public schools? I remember in high school, we couldn't even look up Dick Cheney.
I'm against any way of censorship because that's not how the world works. I don't have a lot of experience on to answer specifically in schools, but I would say that creating environments that are artificial would not help us dealing with the real world and help, in this case, school age people to use resources that are available.
I mean, I'll echo, this is a little outside my domain, but certainly I worry about the slippery slope. If we look at legislation across the country of don't say gay, and you know, how certain political factions are trying to censor what messages can be taught, that can have real devastating effects. And so while certainly I can imagine the concerns of someone, you know, accessing pornography or explicit material in the classroom, other than censorship, one, I would imagine, I have no clue if it's rare or not, but these are teachable opportunities, learning moments, and a chance to improve, you know, as Dr. Levkoff said, literacy, you know, sexual health literacy. And so censorship just sort of is a blanket way of destroying that conversation, in my mind.
Thank you so much. I know in my school, those firewalls were very tight in being able to look up anything related to sexual health. I do have a question myself, as long as nobody else does. I don't think so. Trying to figure out how exactly I want to ask this question, but I know that a lot of sexual health is aimed, and education is aimed more towards adolescents, and that's primarily the focus, because that's where you start to have like the most questions, and that's when it's most acceptable to start learning. But I'm much more curious to see what you think regarding, I guess, sexual health education among adults, since it seems like sometimes you reach that age and you're like, I should have known this by now, but I don't. And so I was just kind of wondering if we could have a conversation about that and what kind of experiences you've had with that in your own work. And I don't know if it's a specific question, but I'd like to start the conversation if you guys are willing.
Yeah, I think that we have this idea that there's a magical window for sexuality education, and that everything you're supposed to learn in this window. I mean, maybe, right? Obviously, there is information to be learned, skills and tools to be gathered, confidence to be developed throughout the lifespan. I mean, even the most exciting thing about being a sexuality educator in 2021 is even the how expansive our definitions and language around gender is. So, you know, that's information that adults don't have. So I think that there should be constant education. The truth is, my adult population students ask the same questions that my younger students do. So if I could wave that magic wand and create mandatory, you know, sex positive, inclusive, empowering sexuality education, you know, every year for one's entire life, I would love to do that. If you could figure out a way to do that, that would be great.
Yeah, I mean, that's one of the biggest challenges, of course, is that teenagers and adolescents are low-hanging fruit. And by that, what I mean is they're a captive audience. And once you emerge out of the high school, you know, another captive audience are university students, but not everyone becomes a university student, nor should they necessarily have to. And so the problem is, as folks get into adulthood, you know, where are they learning their lessons? From my you know, patient population, a lot of them are learning it from pornography, which has its pros and its cons. A lot of them are learning it from apps such as Grindr and Scruff and Tinder. And the problem, again, with these modalities is it sort of leaves the individual to make their own interpretations. And, you know, what do they learn about sex? You know, pornography is a very airbrushed, romanticized to fetishized narrative of sex, depending on what an individual seeks. And there is no balance. You know, if you have a certain niche that you're interested in, you find that, and that's where you land. So one of the things to really think about from a public health perspective, and I'll let Dr. Rodriguez think of this one, and you know what Dr. Levkoff said is, how do we get this information to not our low-hanging fruit, and to people who are not captive audiences, but who are out there needing it, wanting it, but it's unclear where to go.
And my response would be, although I don't like the word normal, because what is normal? But I will normalize the conversation about sex. Something that I share in my classroom or with my mentees is that we should talk about sex the same way we talk about food. And here is the thing, we all need to eat. And we might have different preferences in what we like to eat and how often, but sex is just like that. We can have different preferences. We might like it in one way or the other. And we might be different, right? So I might be vegetarian and I can talk with somebody who loves seafood. And that doesn't make the conversation awkward. We can learn from each other. And at the end, we're talking about food and our relationship with food. So we can do something similar about sex. However, in order to do that, we need more people like ourselves here who are comfortable talking about sex, taking the lead and normalizing and making it easier for everybody to raise questions, to share that uncomfortable information that they feel that is uncomfortable, but might not be uncomfortable as part of a conversation with somebody who knows a little bit more or is a professional in the area. And in that way, I think that we increase the visibility that is needed to be comfortable about to talk about sex. We have a challenge with that, and is how regulated some communication channels are that sometimes prevent from us to have comfortable conversation about sex. So it's not easy to talk in media, and I think all of the panelists here have some level of experience in interacting with media and talk about sex. And often you have to carve those experiences, or in fact, you might be invited to talk about something and then you turn it and talk about what is important. That's most of the time what I have to do. Often my invitations to engage with media have to do a lot with HIV and LGBT health, and from a very pathological perspective. So I take the invitation and I turn it into whatever I believe is important for the audience, right? But that's because we know what is important to have out there. We can answer the journalist questions, but we can also give a message that is beyond just the idea or the question that is being addressed. And in that way, I think we start facilitating a conversation and making the issues around sexual health a little bit more palatable and just available, accessible to different audiences.
Thank you guys so much for answering my question, non-question. I really appreciate it. Adam, I think you had one more question. If you wanted to wrap up our Q&A section, go right ahead.
Thank you so much. Yeah, so my last question is also still related to COVID. It's a little bit more specific, but I was just wondering, how has, in your opinion, how has the pandemic affected the acquisition of healthcare and primary care, like different for mental health purposes and for HIV / other sexual things? How has it affected the LGBTQ community's ability to access those resources necessary to ensure their prevention of HIV and other diseases?
Sorry, Adam, we can have a full panel to answer your question. But briefly, I am doing that kind of research. So briefly, the access to primary care was very disrupted by the pandemic. Most organizations were not ready to continue providing services, any kind of service. We were not ready for the pandemic. When it comes to HIV, STI prevention services, it took a little while. In average, what we are seeing here in the DMV area is that took about 3 months for organizations to get back to kind of the same or similar services in terms of capacity as they were providing before the pandemic. For the LGBT community, and I will leave this to my colleague here, probably he has more personal information based on the encounters, but what we're seeing is an increase on needs for mental health services. that were not necessarily available. And something that I would like to mention, because I think it's across the board when it comes to health services after the pandemic, is that we are praising a lot the fact that we have pine out to use telemedicine and web-based services, but that is creating a technological gap. Not everybody has the same access or ability to use technology for their well-being. And I am seeing that just increasing some disparities, particularly among racial and ethnic minority groups in the United States. So I can speak for hours about this, but I think in a nutshell, that's what we are finding in our research.
Yeah, I have very little to comment on that because I don't have a research perspective. I only have the personal perspective. And I would agree that, number one, of course, when the pandemic started, all healthcare services lacked. And again, if you think about pecking order, sexual health generally goes to the bottom. And so, and in the middle of a pandemic, maybe that's okay. Although, it would be interesting to see. I certainly can tell you the number of online sexual offenses that I've had come across my desk has exploded. So people were at home on their computers, not necessarily doing good things. So, and I don't know how it's related to sexual activity. I asked one of my close primary care doctors who serves LGBTQ population, and he's like, oh yeah, we're still seeing STIs even in lockdown, that people are there, they're having sex. So, time will tell, but I would say that this telemedicine explosion, I think overall will be positive. And eventually when that technology gap catches up, I think access will definitely benefit. So I'm excited by that change for mental health and for physical health concerns, the ability to now, from home, people to be able to see their providers and get this important type of care.
Thank you so much. That was really great responses.
Adam, I will say one more thing, and again, Dr. Levkoff may have some thoughts on this as well. The issue, of course, now is what will the technology do? Part of in the world of psychology and mental health is having a person in your room and doing therapy with them. And now with so many patients who are going to say, well, I don't want to find parking. I don't want to have to, take time off from work and circle around and try to find you. And so, preliminary studies I've seen on psychotherapy and telehealth has shown that it has, quote, equal, at least satisfaction, but we don't know about efficacy. And so for these important conversations, I don't know what it's going to look like with my patients on Zoom, perhaps, multitasking on the side, some providers maybe multitasking on the side. So, for the improvement in access, I think there's a huge question mark about impact and efficacy, particularly in mental health.
Yeah, I would just add briefly, because I'm sure everyone has other things that they want to do and listen to. But so much of education, I love having access to virtual education because it means that at least some of my students can get something. That being said, there is so much of sexuality education that is a performance, right? It's I'm going to say flirtation, but I don't mean it in a sexual way. Looking at one of your students and knowing they are seen, they are validated, they are connected to you and that they can trust you, which obviously is really hard to do in little boxes on your screen. So I love that we have some options, but I never want to give up that in-person connection, which I think is just so critically important.
Thank you all so much for your additions to our discussion today. We had just one more thing we wanted to do with you all before we sign off. I was wondering if there's any way we could get like a photo. And so I think Adam is going to turn on the spotlight feature. He's going to help me out with that. And then we are going to take a quick screenshot So if everybody would smile, that would be fantastic. All right.
So I'm gonna spotlight. Would you like me to spotlight everybody in the entire thing or the speaker? I think this, if it's everybody, it might be too small. Or what do you guys think?
The speakers are fine. I'm sure I'll be small at the top. I do not need to be featured. Perfect.
Oh.
All right.
Let's get.
And perfect. I should have them. Thank you so much. Thank you so much for your time today. We really appreciate you coming out to speak with us and discussing the topics surrounding mental and sexual health with us today. So for now, I will hand it over to our moderators for our healthcare, administration, and advocacy panel. And I hope you all have a great rest of your day.
Hello, and welcome to the Healthcare Administration and Business Panel. I'm Alyssa Stathopoulos, president of GW-AMWA, the American Medical Women's Association, and I will be co-moderating this panel with Katie Lee, the social media chair of the GW Pre-Health Association. We are so happy to have 3 panelists here, Dr. Lois Mills, Dr. Brian Williams, and Dr. Catherine Broad. I'm going to hand it over to Katie to briefly introduce our panelists.
Thank you, Alyssa. I'll start by introducing Dr. Lois Mills. She is the Vice President, Human Resources Chief People Officer at Otter Bean Senior Life in Ohio. Our next panelist is Dr. Brian Williams, who is a professor of trauma and acute care surgery at the University of Chicago Medicine and founding program director of the Adult Surgical Critical Care Fellowship. Finally, Dr. Catherine Broad is the president and CEO at Leading Age Ohio.
Start us off, can each panelist please briefly tell us a little bit about yourself and how or why you chose your specific career path?
Okay, well, I'll start. Lois Mills, thank you for that kind introduction, for allowing me to be on the panel. For me, I have a little bit of a different career path into healthcare. My undergraduate degree is actually in engineering, and I worked in engineering at Procter & Gamble and Johnson & Johnson for a number of years. While there, things changed, and I decided to look for some new opportunities. Still, at that time, I had changed into HR, and I was working on HR and leadership development. And so I decided it was time to change, and I was looking for something new. I thought healthcare made sense because my own experience with the healthcare system had its pros and cons. So I was looking for a way to impact healthcare, had not thought specifically about long-term care, senior services, but an opportunity came up. Also, it was 15 minutes from my house, no downtown driving, yay. So all those factors led me to check it out, and I've been blessed to be at Otterbein now for 12 years. And it's really different working with our staff, trying to have our staff care for the residents, but seeing the residents, seeing your customers every day and knowing you're making a difference in some little thing you might do. So that's mine.
Well, I'll go next. Similar to Dr. Mills, I began my career as an engineer. My undergrad was aeronautical engineering. I went to the Air Force Academy, and after graduation, I served on active duty directing research and developmental test programs. So I had a delayed start to medicine, was not part of my initial career plans, but about 5 years into my military service, I spent a lot of time with a number of people that were in healthcare, nurses and doctors, and I had some friends that were doctors. So I slowly got drawn to this field of medicine and decided to switch career paths and go to medical school. So I was what they call a non-traditional applicant. And I started medical school when I was 27, 28, when most people were graduating and becoming MDs at the time, but I don't regret it. Definitely has been a rewarding career path. And since then I chose trauma surgery. Well, actually trauma surgery chose me. It was a specialty that grabbed me during my medical training. And I've kind of been on this academic surgery career path at major centers, working at the county hospitals that serve a primarily underserved and indigent population, that is also high volume trauma, high acuity trauma. And it's been a great ride, and I'm looking forward to doing it for many, many more years.
Well, I'll go next. I'm Catherine Brode. I am not a physician, although I appreciated that intro. I'm not a physician, and I entered the healthcare field in a rather odd way. I have an undergrad in math and received an MBA in finance, and at the Wharton School, I ran into my then future husband, and he was getting an MBA in healthcare administration. So I graduated and began at Deloitte & Touche and watched my husband's career and concluded that I found much more joy in what he was doing, or would find much more joy in what he was doing than what I was doing. So I left public accounting and moved into the role in long-term care and have been there ever since. And I most recently became the CEO of a trade association that advocates for aging services. And this past year, during COVID, have had a far more regular, in fact, weekly and semi-weekly engagement with physicians in long-term care, and have seen a connection and the nexus between business and medicine in a way that, frankly, if you had asked me pre-COVID to be on this panel, I'm not sure would have had a whole lot to add, but hopefully that this past year has really engaged me in a way that hopefully I can give you a few things, a few tidbits today.
Thank you so much for those answers. I think it's really helpful and interesting for us to hear about all the different opportunities and pathways for different careers in healthcare. Our next question is, how has your business knowledge impacted your career in healthcare, or vice versa? And why is it important for people going into healthcare to be knowledgeable about business?
I'm not so one of you.
All right, I'll start there. And apologies for IO East. This past year for me was an opportunity to see how important it was for physicians to have a sense of business and business practice. And here's my example. In Ohio, as in every state, long-term care was very slow to be able to access testing, to be able to access the kinds of PPE rather, and needed in order for long-term care residents not to create a surge into the acute care space. And so we ended up having very regular meetings with physicians to figure out what we could be doing to help avoid a hospital surge in Ohio. And a business model of addressing the long-term care setting was created in Central Ohio in one county. And it was a physician who was so committed to the challenges and trying to avoid a hospital surge. He mobilized volunteers. He mobilized the local health department. He found through the local health department access to testing that he would vet. In other words, if they would give him the tests, he would assure them that those tests were being used in the most effective, efficient way. And he then would be the resource for that local long-term care facility to contact when they had a resident who tested positive, or staff, so that they didn't immediately go to a hospital setting. It was so effective. It was so efficient. It was such a useful way to use resources that we immediately wanted to learn how to scale it. And using and making sure that you had business skills to do that was a challenge. And so it actually took a number of months before we had an effective business solution that could go to the state and allow the state actually to, they have now provided the funding to help scale this model. But, you know, with that physician not able to access some expertise that could help them get there, we would have been so much slower to really roll out a program that was incredibly successful at serving the needs and keeping the needs of aging elders in the state of Ohio met. So I just wanted to give that example of one physician of long-term care and testing and cohorting early. This was in Franklin County, Ohio, happening far earlier than it was happening in any other part of the state, thanks to that one physician. So I'll hand it over to Lois or.
Well, yeah, since Catherine's speaking of long-term care, I will jump in. As an HR professional, I like to think of myself as a business partner with HR expertise. And so for us in healthcare, especially in long-term care, as you've probably heard, staffing is extremely challenging. We hire a lot of lower wage workers, and unfortunately, many of them are working but living in poverty, even working full-time. Part of that impact we have is Medicaid and Medicare are our key sources of income. And Medicaid does not necessarily pay what it costs us to care for a resident. So we're always trying to balance that income with our expenses, staffing being the biggest expense. So as I want to look to raise wages, I've got to look at how to justify that. What's the ROI for that while we're trying to manage that very limited income stream? Likewise, benefits are another big part of our costs, and benefits are very important to people. But unfortunately, a lot of our staff chooses not to get benefits because of the cost. So I'm constantly looking at how can we reduce that cost, so the cost of providing benefits to our workers who are providing the health care to our residents is affordable for them. And affordable, of course, varies across the spectrum. So I think it's really critical for anyone in healthcare to have a good understanding of the business model, no matter what your role is.
Yeah, I have to echo all of that as far as what it means to have some business acumen despite what your role is in healthcare. And I'll use myself as an example. As a frontline physician, I had no formal training in business. However, to have that will give you a global view of how all the systemic issues and how those all interrelate. When I went to medical school from 97 to 2001, that was just at the beginning of managed care taking off. You started to see a lot more doctors that were getting MD/MBA degrees. And at the time, it seemed there wasn't a whole lot of support for that. People thought it could be a waste of time, but fast forward 20 years and they proliferated. It seems you see a lot of MD, MBA programs, a lot of MD, MBA practicing physicians and administrators. So for me, I've had to kind of gain that knowledge on the fly, mainly through my administrative work, but to actually have this sort of training, I think could make any person that's in healthcare a much more valuable asset. Just knowing the language, having the knowledge, and being able to look at things from a more systemic view can help to transform healthcare so that it's more equitable for all.
I had a conversation with the head of gerontology of Ohio State this past week. And she noted, and actually the Department of Gerontology is in the School of Medicine at Ohio State. And she noted that she has made it an absolute habit in every class, social work class, others, to insist that they consider taking some classes in business. And her point was that everyone, she said, I'm going to assume that everyone in this class is successful. And if you're successful in what you do, you're going to be promoted. And when you're promoted, you're going to be given responsibility for some portion of a budget. And without a good common baseline understanding, and we just heard Lois talk about trying to figure out the ROI on decision making. That's just going to, if you can have that become not something that scares you, but something that you can embrace and feel comfortable with, it is going to serve you so well. You don't have to love it at all. And I'm guessing you're not going to love it, but to be comfortable with it and not be not be resistant to it is going to be super important for your careers.
Mm-hmm.
Thank you, Alyssa and panelists, for those responses. We will now focus more on COVID-19's impact on the healthcare industry. So my first question for you guys is, how has your role as a healthcare provider impact patient needs and workers during the pandemic?
Well, for me, I mean, I trauma surgery and critical care. I have two specialties, so we did not stop working during the pandemic. In fact, we began to work more as a result, particularly in the ICU. In the beginning, a year ago, there was no vaccine. That was during the first surge. Hospitals were overrun coast to coast. So the day-to-day work for us continued and increased for the entire year. There was no lockdown for those of us on the front line. So what I learned from that is how important it is for, again, the entire system to be on its A game in order to weather this crisis. That involved having frontline healthcare workers, that involved a lot of our hourly workers that you may not think about, that are taking care of hospital food and cleaning the hospital, administration. Everyone had to be on their A game to get our healthcare system through that crisis. And for me, lacking the business training, but having a lot of administrative responsibilities, I had to spend a lot of time communicating between the two different groups. So it was somewhat of a one-year-long crash course in executive leadership that came from the pandemic, but also allowed me to put all the skills that I've worked for a couple of decades into use, because that's why I got into medicine in the first place, was how can I help people in need? And 2020 and the pandemic was the coalescence of all of those issues for me that I get to put in practice for the entire year, and I'm still putting it into practice now.
I'll add to that. I could talk for hours on this topic in terms of the effect of the pandemic on long-term care and on seniors in long-term care, but let me try to narrow it down to a couple of key things. In terms of the patients or our residents, very, very challenging, as you may be aware, for senior care. At least in Ohio, we were essentially locked down where people could not visit. So you could not visit your mother or your father who was in the nursing home. So what I learned about that was the incredible creativity and care of our staff, from things like window visits, Zoom calls, FaceTime calls, just a variety of ways to care to try to get the residents some connection. The previous panel talked about the social determinants of health, and of course, connection and engagement are part of it. We weren't even allowed to hug our elders. We weren't supposed to because of the risk of transmitting COVID. So for many of the residents, then also early on, as we were trying to learn how to prevent the spread as much as we could, there's a lot of isolation in their rooms. We had to stop congregate dining. So we had to bring food to their rooms. So all those factors really made it very difficult for our elders. On the staff side, similarly, we didn't shut down. We're 24/7. We needed people to work. So we had some very difficult conversations with some of our staff whose families didn't want them to work because of obviously the risk of getting COVID. Some people had to choose to leave, and we had to choose to let them leave because we needed them to work. Catherine spoke to PPE, very hard to get at the beginning. So to the point where we had to wear masks, excuse me, not we, I'm in our home office, I wasn't in the nursing home. I wasn't allowed to go to the nursing home, but the nursing home staff had to wear masks and had to reuse them for up to a week. So you can imagine breathing into a mask for 8 hours a day, putting it in a brown paper bag with your name on, and come back and using it the next day for a week. It's what we had to do because we had to take care of our patients, our residents. So, what I really learned was the resilience and of people and the concern and care. The last thing on the flip side, We did a lot of testing, we led testing, and we found, a lot of different things. Vaccine, yes, it's here, it's going to change things. Well, to our surprise, only about 40 to 50% of our staff is getting vaccinated for various reasons I won't go into. But what happens now is if we do have, although residents are 95% vaccinated, if we do have one of our staff who didn't get vaccinated test positive, then we have to isolate the residents again for 14 days. We call that COVID jail. And so it's continues to be very challenging as we work through this. But I'd say the biggest learnings is that people working together can solve problems, and we have made tremendous strides, but it continues to be very challenging in senior care. Catherine, you're still on mute.
Well, she may have unstable connection. I just want to add to what Dr. Mills just said when you said we had to do this and you changed it to say not me. I think that's kind of a really important, I guess I wouldn't say slip, but it's actually kind of true. We had to look at ourselves as a collective unit. It wasn't just who's on the front line, who was at home, who was working hourly. It was collective. Like, we were in this together. We all had our roles to play. We all had to do it. Like I said, we ought to be on our A game for it to be successful. No one group, no one individual could have gotten the healthcare systems through the pandemic without some sort of collective mindset. So when you said we, Dr. Mills, I echo that. You may not have been wearing changing your masks every day, but we understand that to get the masks, we needed your help as well.
Yes, thank you. Yeah, I totally agree. It was we. And I have to say, Adam, thank you for the promotion, but like Catherine, I'm not a doctor either.
And that was exactly what I was trying to convey before I lost connection. That the importance of having physicians in the hospital understand what the care was in the long-term care area that was taking place. We found out there was a huge disconnect in understanding. So physicians in the hospital didn't really understand what was happening in the nursing home. They didn't understand that a nursing home was different than assisted living. And the importance of having a good line of communication between the two was, we have a couple of case studies in Ohio that showed how effectively it could work together when the hospital and that long-term care facility were really tied at the hip in terms of understanding what one another was doing. And it's especially important for physicians who are discharged to understand what home is, and to understand, is there food in the refrigerator at home? That med that he's just or she's just prescribed, is the way by which that person's going to get it and then be able to effectively take it if food is required. Understanding those social determinants of health are so important, and it requires a knowledge of that patient, where they're going to be cared for and what kind of care they're going to get. And we learned a lot during this pandemic about where we needed to improve that communication. And the second point I was going to make is that my role is an advocacy role. We also had to be educating the State House and our legislators. They needed to understand what our needs were and what we could do and what we couldn't do. And right now, we are struggling so mightily with staff. We need for them to understand that because they make policy suggestions that we sort of chuckle and say, that would be great if we had the staff to do them, but we don't. So just increasing the knowledge, the more we can do to increase knowledge across the continuum, the better.
Thank you, panelists, for your responses. I really appreciate you guys taking the time to talk to us on Sunday and sharing your experiences during the past year. And my final question for you guys to wrap up this topic is, as we transition to a post-COVID world, what do you anticipate will greatly impact the healthcare industry's relationship with the patients?
Well, let me start because I spot right now and I don't know how long I will be. I heard in the last panel the importance of telehealth and yet the challenges of it. And one of the areas that we represent for aging is affordable housing. And I really sense a digital, I don't sense it, it's well documented and there's been much discussion about it, but particularly in the area of aging, that digital divide is one that is causing there to be an us and a them that is particularly challenging. So in the state of Ohio, if you live in affordable housing and you need additional services, perhaps telehealth could help you stay and receive or be diagnosed in a way that you don't need to be transported or moved to a higher level of care. But the lack of telehealth capabilities, broadband, and access to broadband makes it pretty likely that if you need additional care and you live in affordable housing, you're probably going to be going to a nursing home. Whether you like it or not, that's just simply going to be the only option. So I really hope that the governor of Ohio has just signed a bill that's going to expand broadband, but that isn't just the only solution. We now have to make sure that devices are available, that education has been provided, and that a senior who's in a building that now has broadband actually does have all the tools that are needed in order to access that healthcare they need. So there's a lot of work ahead in order to make sure that we really access this amazing capability in telehealth in a way that really affects the needs of spectrum, particularly the aging.
And again, I'll jump in and add on to what Catherine's saying in terms of, I think one of the bigger questions in healthcare going forward is going to be, where is the patient? We know because of the pandemic and the effects of COVID, many people are more reluctant to come in, say, to a nursing home or assisted living when they may need it. We also know those are expensive forms of care. So home and community-based services are really a good future, well, current and future model. But again, from the patient perspective, how do you access that? How do you make sure you've got good trust providers? From the provider perspective, how do we get the staff that can go and provide that care, in the home, in the community? And so you put all that together, that provides a big opportunity for healthcare and healthcare innovation and change, and also a big challenge because the last side of that is, again, back to social determinants of health. Just say, I'm staying in my home and I'm gonna, live here. Well, that's great, but you could be isolated. You don't drive, you don't get out, people don't come to visit. So you're in your home, but you're not really thriving. So I think finding the right balance of where care should be, how it can be provided, and how do we also keep people engaged in life will be some challenges that hope many of you going into the healthcare field are going to help us solve.
I think this is possibly one of the most exciting times in medicine, that out from this tragedy, we can actually transform healthcare in this country if we take a interdisciplinary approach, if we're patient, take the long view and consider that the changes we need will take decades to occur. But what we've seen that so much of the unnecessary death and suffering that occurred was predictable, and the solutions are there. It's just a matter of putting them into practice. And right now, going into 2021, 2022, there's a saying that the best time to plant a tree is 10 years ago. Well, now is the best time to plant our healthcare transformation tree for the next generation. And as you go into your respective careers in healthcare, you think about that, take the long view and recognize that the COVID pandemic is our opportunity to wring some good out of a tragedy that could have been lessened if not avoided. But let's not forget the lessons learned. Let's put them into practice to transform healthcare for the future.
Amen.
Thank you, Katie, for those COVID-related questions, and thank you to our panelists for your responses so far. My next question is advocacy-based. So has the topic of biases in healthcare become a more prominent discussion in recent years? And what advice do you have for future healthcare professionals who want to provide equitable and equal care to patients of different races, ethnicities, and cultural backgrounds?
I mean, how much time do we have left? I mean, I could spend the rest of this session talking about health equity. We haven't learned one thing from COVID, is that we have to look at everything through a lens of health equity, because we are all interconnected in ways that we may not appreciate or understand. But we look through the healthcare system through a lens of health equity and understand that the most vulnerable amongst us, by providing equitable care for them, we all benefit. Then that is another lesson that comes from this pandemic. And I think there have always been many people and groups that have been speaking about that over the years. I think 2020 brought it into laser focus for a lot of groups and individuals who may not have been aware or may have dismissed it as not being that important. But now it's clearly clear that we can't turn away from that. So moving forward, looking through healthcare through the lens of health equity should be a prime focus for anyone in healthcare.
Yeah, I honestly can't add much more to that other than I absolutely agree. And we have learned, again, not just racial disparities, but age disparities and how we treat our seniors. Many good things and some things we can learn from. So if we don't use this opportunity as a country and as individuals to really look at the lessons learned and then what do we do differently, as Dr. Williams is saying, then really shame on us. Looks like we may have lost Catherine.
No, I don't. Dr. Miller said it's racial disparities, age disparities, ethnic disparities. We have prisons. I mean, there's just so many different layers. That geographic. Really what connected the folks on the south side of Chicago, where I work, to people in the mountains of West Virginia, there were still similar issues of health equity that impacted outcomes. And there are so many disciplines that are involved: criminal justice, geriatrics, trauma. There's not a lack of how someone can get involved in transforming healthcare. But if you pick your niche and do that to your best of your ability and always focus on what is it you're doing for the common good, that's how we move the needle forward. We can't be everything to everyone, but we can be the best at what we do and staying within our lane. And then through that, we can transform healthcare for the better going forward.
Yeah. I think I would add to that too, that as Dr. Williams was saying, there's a lot of need for interdisciplinary work, connectedness, because it's all a system, all connects together. So the work you're doing even today, putting on this summit, working together, you all have heard different clubs. When you introduce yourself, I'm in this group, I'm in this group, but you've worked together to put something good to help a broader audience. Those are the same skills you're going to need no matter what area of healthcare you go into to be part of this transformation. So I applaud you for the work you're already doing and learning that critical skill of building coalitions and relationships.
Absolutely, which reminds me, I think I didn't answer the actual question, which was about advocacy and the importance of that. And Catherine mentioned how it was important to be able to transmit or translate our experiences to policymakers, local governments, state governments, the national government, because as we've seen throughout the pandemic, that when public policy is weaponized, people will suffer. People do suffer from that. So advocacy is extremely important and being effective about it. It's one thing to scream into the wind about something you know is right. It's another thing to be an effective advocate to get your ideas and your opinions advanced to serve the greater good. So do not minimize the importance of advocacy in the work that you do, or you want to just become, like, make that your role, is to be a healthcare advocate in some way. Extremely important.
No, you're right. We didn't quite answer the advocacy part, and I would totally agree. It's something I've been doing the last couple of years. As an organization, we go to, well, we had been going to Washington. This time we did it virtually, but to advocate. And if you go, you'll see, you have 15 minutes with your senator, really with his or her aide, but there's a whole line of people. So there's a lot of people advocating to our policymakers for their view of certain things. So you have to be part of that. And also feel free to invite a policymaker to your club meeting, to your practice when you're out in the world, whatever you're doing. Seeing is believing. So that's another part of advocacy, is inviting them to see what you're doing.
And I love this. We keep on going. Another part of advocacy is communication, right? If you have 15 minutes, you need to get your idea across in that time. You don't get to ramble. Like, what is your point? What is the reason you want to? Like, how do we achieve this and get to the point? If you lose that person within the first few seconds, just forget about it. So communication is key. Verbal communication, written communication, those are all skills you need to work on as well. And that comes with in business as well, right? You need to communicate to your organization why we're doing X and not doing Y. These all are very important skills to have.
Yeah, absolutely. And most importantly, don't forget to make the ask for what you present everything and think they got it. No, you got to be clear. What am I asking for in business and advocacy and everything?
Well, somebody told me, one of my mentors told me, closed mouths don't get fed.
Yeah.
If you don't ask for it, you're not going to get fed. Do not assume that they know what you want. Great point. Great point.
Closed mouths don't get fed.
Thank you for those responses. Now we're going to open it up to questions from the audience. So feel free to type your question in the chat and we can read it aloud, or feel free to unmute yourself and ask your questions.
I have one question, if that's okay. It's related to how do you guys feel that technology will be changing the healthcare the landscape, and how that will affect the business model for which, I especially see this in senior living and senior geriatric care, but how might robotics, things of that sort, change the way in which we provide for our elderly and also provide for our patients in the ICU, to name a few offices?
Well, that's an excellent question, Adam. Technology, again, has lots of different variables, and some good, some challenging. Certainly, we've made the change to electronic medical records, so our staff had to learn how to use computers better. Some of them, particularly some of the older staff, weren't used to working with computers, still don't like it for some of them, but they're doing it because everything is, going into electronic records. If you go all the way to robotics, interesting concept. I know in Japan, they're doing some development of robotics for healthcare to replace nurses' aides. And it's hard to think about, Robert lifting me out of bed and putting me on the toilet, for example, or, helping me to stand up to go get dressed. I suppose it could happen. Certainly it would help staffing challenges, but I don't know if that's how much technology is too much. If we want to care for people through a robotic person, I don't know. It'll be interesting to see.
Yeah, that's an interesting question. And I think healthcare is, it's in line for a technological overhaul as well. And there are so many domains that can be done. Like Dr. Mills mentioned electronic medical records. There should be seamless access to records, but also there's also a issue of patient privacy and breaches, and what does that mean? So cybersecurity is important. So for example, the VA health system, which is the government-run health system for all veterans, you could be anywhere in the world and access patients' records. So if they're in California, then somehow end up in Florida, you can log in and get their information and give them the appropriate up-to-date treatment. However, if you, that are not in the VA hospital, go from one hospital in your neighborhood to one across the street, they will not be connected. So you basically start at square one, get all the information. So how can we share that information seamlessly, but also securely to not violate patient privacy? Another example that I deal with in my day-to-day as a trauma surgeon is that sometimes someone may be in a car accident at one hospital and then be transferred to us. While they're there, they get a workup, they get x-rays. When they arrive at our hospital, they may not have all of that. And it's not easy to get that information sent quickly. So you have to start all over again to do that entire workup to make sure they're safe. We can't take a chance that we're missing something that could be life-threatening. So you think about the time that's added to that, the cost to the healthcare system overall, and that's happening on a scale across this country that is kind of hard to fathom. Robotics, that's kind of being used in surgery. Some surgeons use robots to assist in certain very fine type of procedures. So it has a role, but also a robot is expensive. And for the number of cases that you do, is a return on investment worth it? That is to be debatable. Then you're asking other questions, very ethical questions, right? How much is the patient's life worth? How much is a complication worth when it comes to the human cost? So that simple question there about technology, there are so many other things to consider that it can impact when you think about how that could be utilized going forward. But in short, I think definitely technology can be a benefit to healthcare overall.
And I would add to that, again, that technology and business connection. Previously, I worked for Johnson & Johnson, and one of the divisions that made surgical instruments or for more less invasive surgery procedures, laparoscopic procedures. And often what we found were barriers to the hospital wanting to use that because that particular instrument was more costly, say, to do a laparoscopic gallbladder remover than have a surgeon remove it. But the fact that the patient then didn't have to stay in the hospital 2 or 3 days would save money, but the budgets were set up differently. So operating room had their budget, the nursing or the surgery floors had their budget. And so it's really a whole education, the hospital administration about the total cost of care. So as Dr. Williams was saying, when you look at that and weigh all those factors, that's going to be another, again, back to that business understanding of, what you're to see where the value is.
I mean, because you can imagine a surgeon just saying, I want my robot to do my procedure efficiently. And if you don't have any of that business acumen, you may not think about what it costs to the hospital. You may not care. And even if you do know, it may be less interest to you, but just having that knowledge is important. I mean, think about if you go to a movie theater that has 10 theaters and you're playing movies all the time, that's how you make money. But if you have one theater that can only play cartoons and it's not playing any cartoons on one day, that theater is not making money. Same with the robot. The robot will take up an entire OR that can only do those robotic cases. If you're not scheduling cases, that is money that's not being made for the hospital, but where you can't store a robot somewhere else. So just always keep asking, like, what is the further impact of this decision? You keep asking why, you will get back to an answer that can help you to really inform you for what you're going to do. And that takes business sense, a sense of looking at the bigger system, focusing on the greater good. I mean, you all is coming at a great time to healthcare. Like this is such a fun, transformative time that it'd be interesting to see what you all accomplish 10, 20 years from now. It's going to be such a different landscape. I'm excited. Take care of me, please.
So that's what I'm saying. I'm going to be one of those you're caring for in 10, 20 years. So get it right.
Get it right.
We have a follow-up question from Rosie who asks, similar to what Adam asked, what are your opinions on automating check-in procedures? Like, for example, replacing all admin staff with technology?
I'm nervous about anything that says all, but certainly, I agree. Some basic things that can be done that are repetitive, they're easy to do, as long as the technology is easy to do it with. We've all probably dealt with you call and you have to go through 10 different, do this, type this, 0 for this, 1 for that. It's like, I just want to get an answer. So if you're going to have procedures, make sure they're quick and easy and efficient to do, so that people, patients feel they've been cared for and not frustrated. So I don't think all admins can go, because just like today, systems don't always work. So you want to have a plan, and some people still will need a personal touch.
Yeah, I think that's such an interesting thing to think about. As I'm trying it over in my head, I can see a lot of benefits to that, but also see how that loss of that human interaction for healthcare, it is such an important relationship between the healthcare system and patients. Like, what does that mean? When I think about other things in my own life that have changed due to technology, I remember before, when I had to fly, I had to go through a travel agent to get my ticket booked. Now I get online and do it myself. Just yesterday, I went through CVS and checked out all my items myself, never talked to anybody before I bought my items. So there are these things in our day-to-day lives that have changed over the past 10, 20 years as a result of technology that we now do ourselves, that used to require another human being to close the loop for us. So I say, well, why couldn't that happen for check-in procedures at a hospital? It's not impossible. What would that look like? I don't know. What would that mean? I'm sure there'll be some transition period that people are resistant, but you look at it 10 years on the road, you may not even remember the time when it was actually different. So I like that. That's a really interesting thought process to go through. Mm-hmm. That's why we need people like you. Keep doing it.
Our next question from the chat is, any thoughts or perspectives on the role of blockchain technology in the future of medicine? What changes may it bring to the centralized system that we currently have?
It's definitely a Dr. Williams answer.
Oh, I'm a claim ignorance. I don't know enough about blockchain to give an informed answer about that. I've heard of it, but I don't know enough to really give an informed answer. And it'd be unfair to you to even attempt to give an answer other than to say, I need to look into that more and educate myself about that topic.
Do we have any other questions from the audience?
Yeah, I have a question. This is probably more toward Dr. Brian Williams, but let's just say if a patient were to have COVID-19 and CHF, and then they were to die as a result of the CHF, what would be labeled on the death certificate? Would it be because of COVID-19 or CHF, or can it possibly be both?
So that's a good question. And so what he's referring to is that when any patient dies, on their death certificate, the doctor has to say what caused their death. And there are actually two blocks of information we fill out. One is what other conditions may have contributed to the death, and what actually was the cause of death. So when you mention someone who had COVID-19 and CHF, congestive heart failure, basically the heart can no longer beat efficiently, and they die. And they died with COVID. So the question is, did they die because of COVID? Or did they die with COVID? And that will vary depending on who's actually doing that death certificate. What we do know is that there are probably a lot of people earlier in the pandemic that were dying of COVID before we knew what it was. And there are probably a fair number of people that are dying with COVID that have been said they died because of COVID. So because it's a novel virus, we still don't have a great handle on that. But the forensic pathologists, the medical pathologists that are doing this, we should have more information soon. But I will say right now, there's probably a combination of people that are dying with COVID and dying of COVID that have other comorbidities that may have been the contributing factor to their death.
Okay, thank you.
You're welcome.
Any other questions from the audience?
If there's no more questions from the audience, I'll ask one more question to end us off. Do our panelists have any advice, such as something you wish you knew earlier in your business healthcare journey for us pre-med students, or any concluding remarks you'd like to make?
I'll jump in to close it. So, my advice is to be curious, to ask those questions, as Dr. Williams talking, ask the why, ask the why, ask the why. What I would perhaps wish I'd done more of when I was at your age was things like this, was getting out of my books. I was very focused, very studious, but getting out of my books and getting out into the world, so to speak, to learn more about your field, but also life. The one thing I'm continually working on, not mastered it, is I don't necessarily believe in work-life balance, but work-life effectiveness. So what's going to be effective for you, even as a student, even there where you can go 24 hours without sleep, but I can't these days, whatever, you still, need to find those things that you enjoy, that relax you, have relationships with, that's not all focused on pre-med and things like that. So find that balance of being curious about life, both for your professional studies as well as for your life, so that you can enjoy and give your best because you're at your best.
And I just want to add, I think it's almost like you and I were like mind melding up there, Dr. Mills. So she said work-life effectiveness. I like the term work-life integration. And I mean, you need to just have fun. Just no matter how serious the jobs that we're doing, we recognize that I'm dealing with death every single week. Like there's not a week that goes by that I don't tell some mother about the death of their child from violence. So it's very heavy, but I do really enjoy the work I do. I think I have the best job in the world, and I don't know that it's important. And I know it's somewhat of a dichotomy that I have fun doing it. And you should be able to bring that sort of curiosity and fun to what you do at work, what you do at play, what you do with your social circle. And don't lose sight of that as you keep moving through your career. You're all smart, going to be successful, but none of us got to where we are by ourselves. Mm-hmm. There are people in your lives that contribute to your success in ways that you may not recognize. And if I could go back, there are so many folks I would have thanked along the way. So just keep your eyes out and kind of stay present throughout this journey. Work-life integration, have fun. And look, if you want to contact me, I'm happy to continue this discussion after the talk. I'm on brianwilliamsmd.com or Twitter. I respond to people. I respond. I like doing this.
Thank you so much. I think we'll definitely have you guys both on for upcoming sessions.
I just wanted
Happy to do it.
Oh.
Thank you.
Sorry. I just wanted to say thank you guys so much for being here, for taking the time out of your busy schedules to be here, and we really appreciate you sharing all of your experience and knowledge with us. So we will take a short break, and I will transition over to Omar, Jackson, and Ishan for the medical innovation panel starting at 1. Thank you.
Okay. Thank you all.
Stay safe, everyone. Have a good weekend.
Hello, Dr. Vinayakom. How are you?
Hi, pretty good. How are you?
Hello, Dr. Cleary. We'll be beginning in around 7 minutes.
Yeah. Okay, great. All right, I'm here. I'll just hang out. Yep. Okay.
Hello, Dr. Benayakum. I believe there's a little bit of an echo on your side. I'm not sure if you can hear that or not.
Yeah, I heard that echo. I don't know how to kill it.
Is it because, do you have two computers on at the same time or two devices?
Maybe, let me.
Yes, that is why. Oh, I see. So I'm going to kick I'm going to remove one of them, and that should resolve the issue.
Okay. I think that the other one is not functioning now. The echo should not be there. Can you hear?
Sorry, yeah, my connection was a little bit unstable for a moment. But yeah, now it sounds like because you had two on originally, it was having a little bit of an echo. But now we took one off, so the audio is back on.
Thank you.
So yeah, thank you so much. Yeah, we'll be getting in about 5 minutes.
Okay, I'll be here.
Thank you. For those that just attended the last event, what did you guys think of the discussion on healthcare administration and business administration? Any thoughts or feelings about it? Thank you, Fatima. I know that we had originally said that we'd start at 1 o'clock, but I think we could begin now. Your other panelist, Dr. Shawn Sarin, will be joining shortly. He was called into the ER to perform an emergency surgery. So he'll be a little bit late, but he'll be hopefully joining us a little later on. So we'll let Ishan, Jackson, and Omar take the floor and discuss with you guys. Thank you.
Thank you, Adam. Hello, everyone. Thank you all for being here for the concluding panel of the GW Health Summit. We are so lucky to have three great speakers who are experienced in special topics concerning medical innovation and novel approaches to Western healthcare. Before we introduce our three speakers, I would like to introduce myself and my co-moderators for this panel discussion. My name is Omar Saidi, and I will be representing the American Medical Physiology Club.
My name is Ishan. I'll be representing Censorship International in Haifa.
Now, our first medical innovation panelist is Dr. Shawn Sarin, which he carries a specialty in the Department of Interventional Radiology along with endovascular management in a close collaboration with vascular surgeons as well as interventional cardiologists throughout the nation with the current development of an informative website for current patients.
Jackson, you there? If not, I can read it. Okay. Well, the next speaker on our panel is Dr. Kevin Cleary, Technical Director at Children's National Hospital, who will lead a discussion on surgical robots and clinics of the future and their ongoing development as they pertain to the medical innovation contributing to Children's National Hospital. And then I'll also take for our last one, Our last panelist is Dr. Kinuluple Vinayakam, a retired professor of anesthesiology with affiliation to our Georgetown Med-Sur Hospital, who is a board certified acupuncturist, and he'll provide a new perspective on the blend between traditional Western medicine and non-traditional Eastern medical practices. With that being said, we'd like to again provide a sincere thank you to our inspiring speakers for being here on this panel today. And we'll now turn the discussion over to you with a few questions. And I can start off by asking the first one. So as the future of medicine begins to stray away from in-person appointment interactions and more towards like or digital appointments, what new strategies do you believe healthcare professionals must develop to build that strong connection and trust with their patients over the screen? And any of you can answer that.
I'll let my clinical colleague go first, and then I'll tell you from a technology perspective, perhaps.
Dr. Vinayakam, if you could respond to the first, I think he was referring to you.
I will respond to the topic which I have already alluded to.
So I could say a few things from the technology perspective. You know, I think as you all know what happened during COVID. You know, I'm at the Children's Hospital in Washington, D.C., and I run a biomedical device group. But we also are involved with technology at the hospital. And obviously, during the pandemic, you know, when patients weren't coming in for their regular appointments, the hospital clinicians transitioned to a telehealth model, and they used the same Zoom platform we're using right now. So everyone had to get familiar with the technology and, of course, the different ways of interaction with patients over Zoom. But the clinical providers I've talked to said there are benefits. Certainly with children, you know, when you think about getting them to the hospital and taking them out of school and then driving downtown and finding parking, you know, for a physical exam, it's very time consuming and very disruptive to schedules. So they said they actually appreciated being able to do patient consults from the patient side, at least in the home environment. I think the downside to it, of course, is you don't have the same physical and personal sense of touch that you have in an inpatient appointment. You know, one is, of course, just the ability to be in the same room and maybe read your patient, so to speak, better. But then, of course, for exams that really do need a physical exam, you know, if you're an orthopedic surgeon trying to evaluate range of motion, it's difficult to do in a Zoom session, a telehealth session. So I think there are pluses and minuses, but I think it's clear that telehealth is here to stay. And so part of the transition will be, how can we eventually have better telehealth appointments? And it will be interesting to see if patients eventually prefer telehealth appointments versus physically coming. So that's at least my my opinion on the subject.
Great answer. Yeah, that's definitely very insightful. And that discussion about will it ever supersede is definitely something we can talk about later in this panel. I'll turn it over to Omar to ask the next question. Thank you.
Thank you, Shawn. So the next question I would like to ask, and this is one directed for Dr. Vinayakam. For surgeries that must occur almost immediately in an emergency situation, does the 48-hour pre-anesthetic evaluation still occur?
This is an emergency situation where you are getting a patient and we won't be having enough time to evaluate 48 hours before the surgery. For giving you an example, if somebody is coming with an abdominal aortic aneurysmal rupture, we don't have any time. You know, the patient is on the table already, and we have to kind of go ahead with the whatever treatment, immediate treatment is necessary for the patient, how to resuscitate the patient, and how to go ahead immediately with the surgery and taking the situation under control. So you won't be having enough time, 48 hours or anything like that, to evaluate a patient in a situation like that.
Sure. Well, a follow-up question I would have to that would be, what about like the considerations for those among like the ASA, Anesthesiology Association, where one may be more higher risk compared to another patient? How exactly would you do a initial assessment with regards to the anesthesiology?
This patient goes into the category of ASA 5E emergency category. That means that the risk involved with the patient, the outcome of the patient, everything is going to be kind of unpredictable. But he is a moribund patient who is on the table for an emergency procedure.
Thank you.
Jackson, do you want to?
Yes. So I had a question. I guess maybe both of you, Dr. Cleary and Dr. Vinayakam, you can both give some insights into this. But sort of what's the difference between like in the culture, maybe in sort of maybe some of the ethical aspects, like what's the difference between pure scientific research versus working towards patenting an invention? So sort of what are some of the differences between if you're writing a research paper towards working to create a new medical device, for example?
Yeah, maybe I can take the first shot at that, since that's kind of what we do in our research institute too as well. And I think one is they are not exclusively different things. I mean, I would say, quote, in the old days, and I don't want to date any of us, but back in the days when we had Bell Labs and the other big labs where we had labs that were purely research-based for scientific knowledge, and the system could allow that, they didn't necessarily need to have an end goal in mind. The idea to develop new science that ultimately would be applicable to other areas was funded. Nowadays, it's very difficult to get funding even from NIH without a very specific application in mind. So I think, first of all, science has become much more focused because pure research in that sense, to discover the new properties of molecules without an application, is not really funded so much anymore. The other thing is even academic medical centers, and I actually was at Georgetown for 13 years in radiology before I came to Children's doing radiology research. Everybody has a technology transfer office. And the dream of those technology transfer offices is to commercialize things and make big money for the Institute. And, only maybe 1% of things like that pan out. But maybe if they hit that 1% big, like Gatorade at University of Florida, that everyone knows about, that's enough to sustain things. So I think first of all is that scientific research is more focused nowadays, and that when you write a grant application, there needs to be an application, a clinical need in mind. And secondly is that universities do have tech transfer officers and file invention disclosures. But I think finally the point is that inventorship and actually making something commercialization is still a very difficult pathway. There's still the technology of valley of death, we call, that things die. And then companies that build things are very focused on one idea, whereas academics tend to be very diffuse, and have a number of research projects, and companies are very focused. So that's another difference. So that's kind of the general landscape, at least from my point of view.
Yeah, those are some really good insights. That's great. Dr. Vinayakam, is there anything you wanted to
I totally agree with what he said.
That's unusual. Thank you.
I would like to ask the next question, actually. So this is for both of you to address. I was wondering if you could offer some more insight about the relative, future with regards to Eastern medicine versus Westernized medicine, and what might be the interaction between the two. So what might be the interaction between Easternized medicine and technological aspects that we see in the Western culture?
Okay, I think that I should answer to that question. Um, the the Eastern medicine basically, if you know, is about a 3,000 years old medicine. Well, the Western medicine, as far I'm talking in terms of as an anesthesiologist, that if you know the history of anesthesia, Dr. Morton, he's the one who used ether anesthesia in 1846, and that is the first time that an anesthetic agent was used for any surgery. Before that surgery, everything was kind of with all very noisy. Patient will be crying and blood all over the place. That was the type of situation which they faced those days, 1846. But when once Morton gave anesthesia to the patient, 1846, that was precisely September 1846. Dr. Warren was the surgeon who was doing the surgery. And that was a surgery which was conducted on the neck of a patient when Morton used anesthesia for that patient, and that was that is where everything started, and and since that time, that the techniques have has evolved. The anesthetic agents which we have used has changed a lot, and also the monitoring devices which we are using on patients also changed quite a bit. The ancient Chinese people, what they did was they identified about more than 365 points on the body, and they utilized those points to use needles on those points to make the patient better. Let me just bring to your attention why I got interested in Chinese medicine, which is the Eastern medicine. The reason why I got interested is during 1980s, when I was at National Institute of Health. In the afternoon hour, I just go to the library and read the literature, the journals and stuff like that. And in one of the journals, I found out that that the ancient Chinese people, they were mainly doing preventive medicine. Prevention was the main thing which they were doing. Before the disease sets up on the patient, the ancient Chinese people, they will start giving treatment using needles, and they try to keep the condition from progressing. That is what they did during those times. So it was the preventive medicine aspect of Eastern medicine which made me interested in this Eastern medicine, and I was very much interested in studying the Eastern medicine, and I thought that I will be able to use the Eastern medicine with the Western medicine. When the Eastern as well as the Western medicine combined together, the equation is going to be very powerful, and we will be able to take care of the patient as a total physician. Some of the things which the Western medicine people, I was in Western medicine for a very long period of time. Since 1961, I had been practicing medicine. From 1968 onwards, I had been practicing anesthesia. But but when once I started studying Eastern medicine, which I started only since 90, I think 90, 2012, that I found that there was a big gap there in my knowledge, and I studied the medicine pretty thoroughly for about more than 6-7 years, and then I got a board certification on that. By a lot of things which we couldn't do with Western medicine, I could establish by doing that with Eastern medicine. And also, I would like to bring to your attention that in France, that the French system, they were using the Eastern medicine quite a bit, and one of the radiologist actually, but he's also interested in pain medication, pain aspect. His name is Paul Nogier. What Paul Nogier found out was that he had in his pain clinic, some patients came with a portion of the ear mutilated, or in other words, cut off. And he was very much interested in finding out why the portion of the ear was mutilated. And the patient explained to Dr. Nogier that they were having excruciating back pain. And when they went to an elderly lady who was also practicing in France at that time, what she was doing was she was cauterizing with the hot clips on a certain point in the ear. And when once the cauterization was done, the pain lifted. After that, they never had the back pain recurred again. So Nogier was very much interested in finding out why these patients got better, and found out that a particular portion of the ear that which he later on found out was a junction between the lumbar and the sacral area, and that is exactly where the pain was. That when that portion is cut off, the pain went away. What Nogier did was, instead of mutilating the ear, he started putting needles in that portion of the ear, and he got the same results. From then onwards, Dr. Nogier, he mapped the ear for each and every conditions. If somebody has got a neck pain, that he had some, that particular portion of the ear which is suppressing in the neck was having some changes in the form of either some pustule formation or some crust formation or something like that. Using those techniques, he mapped the ear, and he came up with a somatotopic representation of the ear with almost over 300 points in the ear, which represented the entire human body. And in the ear, when he mapped that ear, he found out that there was a homunculus representation, which is a fetus with the head down position on the ear. And he published that paper in Germany in 1950. And then from Germany, it went to Japan. And from Japan, it went back to China. And Chinese people started studying the ear again. They already had the ear acupuncture points, which they mapped out. The ear points which the Chinese mapped out was a little bit different from Dr. Nogier's ear points. So in China, in France, they have come up with a specialty of medicine called it's called the auricular medicine. And medical students from first year onwards, they are exposed to this type of acupuncture points, and they are encouraged to study these points, and they had been very much actively involved in the Eastern medicine. When they combined the Eastern medicine as well as the Western medicine, they could come up with better results. I think that I will stop at this point and allow other panelists to talk about this topic.
Thank you for your insight, Dr. Vinayakam. That was really, really interesting, and I'm sure we learned a lot from that. And we'll further discussion after we ask. We just noticed that Dr. Sarin's here, and we'd like to thank him for taking time. We know he's in the hospital right now. Maybe this is more towards Dr. Cleary and Dr. Sarin. Here's the question. How prominent of a role will artificial intelligence take in the future of healthcare treatment, like more specifically surgery? And do you think that patients' trust of these machines will ever supersede that of human physicians and surgeons?
Well, I have a point of view from technology side, but I'll let Dr. Sarin comment from the clinical side first, and then I'll go. So please.
Sure. I'm very excited about the advent of AI in its application. I think initially it'll arrive as a supplement or augment our existing capabilities. So hopefully it'll be teamwork with advanced tech in things like decision support. It's already playing a major role in emergent procedures like stroke intervention, and hopefully it hasn't really gained a lot of traction for cancer detection on the radiology side, because the people have been talking about it for 10, 15 years. But I think the processing power and the evolution will continue on the diagnostic side to continue to play a role. I don't think patients will mind, because it's probably going to result in better outcomes and maybe even lower costs of care. So I think it's hopefully a win-win, but that's an optimistic view. But it's coming, and people in healthcare have to be wise to it, I think.
Yeah, I would agree. I mean, I think it will play a prominent role. And, we've seen some of this before. When computer-aided diagnosis first came out, we were like, oh, radiologists are going to be out of a job because the computer is going to take over. And then they realized that the subtleties that the radiologist can bring to the task, can't be so easily replaced. And as far as I know, it's only a read right now for certain things. And, breast cancer is a secondary read. So it hasn't taken over. But I think AI is more powerful. When you have your phone and you're going by a store and your phone suggests, hey, maybe you'd like to visit this. And you're like, wow, I was just looking at shoes on the web. That's pretty powerful and maybe a little scary. So I think the thing will be how to use it in the appropriate way. We do some work here with trying to gather large data sets, as we get more large data sets that are what we call annotated, have a clinician read, and then the computer can learn how to do that. So what I've heard is that it won't replace things, but physicians maybe who do not learn to use AI tools, maybe in jeopardy. On the other hand, the patient is always going to want the clinician to explain to them the treatment options. I don't think they're going to want to hear that from a machine. So I think it will hopefully supplement both physicians and patients for a better patient experience. And that's what we should work toward. But it is coming. I think there's no doubt about that.
Absolutely. Thank you so much for your answer. That was definitely great insight. I'll turn it over to Jackson for the next question.
So whether it be working, when you're working clinically with a patient, or whether you're developing some sort of a new device or technique that is to be used on patients, what kinds of input or feedback do you receive from the patients that you are working with, or how do you seek out patient feedback if you're maybe working on something that's sort of more like a device or some sort of a technique?
I will quickly comment again from our side of view. Having been on our institutional review board or ethics board for some time as well, There is more and more of a push nowadays to get patients involved, and you actually have to have a patient representative. And of course, in pediatrics, it's very applicable because particularly for the young patients, of course, it's the parent, who is the representative. So I do think it's important to have patients. I think it can still be somewhat of a mixed bag. That may not be politically correct nowadays because, again, patients may not be familiar with all the intricacies and nuances that go on in patient care, and then sometimes maybe reimbursements and other things drive things otherwise. But I think, that it is ethically, I think, important to include patients in the point of view. And I think we sometimes dismiss that. Even as scientists, we say, well, we know all about the technology. We don't really need a patient to help us decide how we should use that. But since the patient is the one who is receiving the treatment, I think it's important. So I do think considering the patient point of view is an important part of healthcare, and figuring out better ways to involve patients, in development of new technologies, I think is something that is also continues to come and be important.
Yeah, I agree with what Kevin just said. I think that we, at least in our field, in interventional, there's new devices, almost quarterly. Sometimes we use devices in off-label fashion, but a lot of our devices are available through an IRB, and that requires an additional consent with the patient. So I think paramount is including the patient in the decision, in the patient care, in the healthcare team, and having an informed discussion and getting good informed consent from them after describing the use of maybe advanced technologies with the patient, so they're aware of what they're about to receive.
Thank you. For the next question, I would like to ask, and this is a topic of open discussion among all three of you, how would Western nations adopt Eastern medical lessons to actually improve patient outcomes? How can we actually adopt this holistic approach to medicine, combining all of these different techniques for improvement?
Okay, let me just start off that. The holistic approach is basically if somebody has got some problem, that we have to include the Western and Western medicine is taken care of. Whether the Eastern medicine people has got anything to contribute, or that is basically what I think you are asking, right? Am I correct?
Yes, you are.
Okay. Let me just give you one example, which is a NADA protocol, which is used nationally, which is called the National Acupuncture Detoxification Association. What that NADA protocol does is that it is a non-verbal approach to the treatment, whereas the Western physicians are also, like the psychologists, psychiatrists, and other people are also involved in taking care of the patients. These are patients who are addicted to medications like narcotics or alcohol or smoking, nicotine addicts. They use the NADA protocol where they use about 6 points, 5 to 6 points in the year. Combining the NADA protocol with the Western medical approach, you can keep most of the patients out of the drug habits. As a matter of fact, NADA protocol, what it does is, that the side effects of the medications or the withdrawal effect of the medication, once we put these needles on the patients, they tolerate, and they don't have that much of acute reaction to the to the drug withdrawal. And they have, by using the NADA protocol, which is an Eastern approach to the detoxification, and by using the Western approach with the psychologists and psychiatrists and the team working together, that we will be able to get a holistic approach to the patient's condition, and we will be able to take care of patients in a better way. Let me also bring to your attention that not many people, because most of it is ignorance or they don't know much about it. I worked in this field, and there are points in the year which I don't want to spell all the points out to you, but there are certain points in the year which we use, which relaxes the patient, brings the body's balance in a very balanced condition. When once you do that, the anxiety factor of the patient is completely kind of brought under control. And when once you do that, prior to an anesthetic procedure, the amount of anesthetic agent used for patients can be reduced quite a bit. By decreasing the amount of medication which you are using, that you will be able to reduce the anesthetic agent administration to the patient for anesthesia. And also, when we give anesthesia and at the end of the anesthetic procedure, that many patients develop kind of a delirium. Some of the patients, they come out very delirious. They are going to crash all over the place and move all over the place. If in case that you can pre-treat these patients with some acupuncture points, that the delirium which you get with the post-anesthetic, during the post-anesthetic period, can be diminished much better. So likewise, there are so many things, like nowadays we are talking about narcotic problems and patients getting addicted, death from narcotics and stuff like that had been widely publicized. But for certain pain issues, you don't even have to give any medication at all. By using the Chinese method, if in case somebody has got a lumbar pain or something like that, you will be able to take care of the pain problem. Most of the patients, I am not saying for all the patients, but most of the patients, you will be able to bring the pain condition under control. And if somebody has got some neck problem or something like that, neck pain, you can do the same thing. There are certain points in the body that you can use to bring the pain under control. In that way, the prescription of narcotic medications to these patients can be reduced much less or none at all. By simple analgesics or something like that, combined with the Eastern approach, you will be able to take care of the pain issues. There is one situation where I myself was a patient. I would like to bring to your attention that I had kidney stone while I was in India, and I didn't know to whom I should go for the kidney stone treatment, but I knew that there is one particular treatment called the bladder kidney distinct meridian treatment. My wife is also a physician, and she is the only one who was with me at that time, and I was suffering from excruciating pain from the pain as well as discomfort. I'm not in a position to sit properly. I cannot lie down properly. And I was completely having some problem with the pain issue that I asked my wife that, look, that I can just go through some certain points in my body, if in case that she could put some needles there and give me that treatment called the kidney bladder meridian treatment, that I knew that I will be able to have pain relief. Not only I will be having pain relief, but also that it dilates the ureter, where the kidney stone is coming and giving me that trouble, and make that stone pass from the kidney ureter bladder system, so that I can be pain-free. So my wife never had given acupuncture needles in her lifetime, but I told her that she will have to put these needles in such and such a place, and she's an obstetrician and gynecologist. And then I told her how to connect those needles to electricity, and I had the control of that nerve stimulator with me. And after she placed the needle and connected the electrodes, I used the electrical device to adjust the current. And at the end of the treatment, in 45 minutes, I was completely pain-free. And I was hoping that the stone which was creating, I never had any X-ray or anything like that because of the COVID situation. I was very much worried going to a hospital and getting X-rays and stuff like that done. But I knew for sure that I was suffering from kidney stone, and I started straining the urine for after the treatment for about 12 hours. And within the 12 hours on the strainer, bingo, there was a stone which came out after this treatment. So just to think about it, just like that, there are so many things which we can use with the Chinese medicine. Somebody is having a paralytic ileus after abdominal surgery. That there are points in the body which you can use, like the stomach spleen point, and connected to the electricity. The paralytic ileus can be brought under control, and they will be able to pass the gas without any problem. So there are so many things which you can use with the Chinese technique. I leave it like that, and I will give some bit to the other panelists to talk about it.
Yeah, sure. Thank you so much, Dr. I'd like to transfer the question to Dr. Cleary and Dr. Sarin a little bit, and ask your opinion on like holistic care and how, like in your fields, what strides have you making towards providing holistic care, maybe specifically in like post-operational care, or like anything in the matter.
I think that it's always wise to look at every patient holistically, and as specialized and technically advanced as we get, from this point onwards, we should always try to remember that, patients are, you look at the big picture and make sure what you're doing to fix one focal issue doesn't make the overall condition worse. Important not to get lost in the weeds and things like that. So I think it's very wise to always look at the big picture.
Thank you. Let's see, what was the question?
Hi, I have a quick question. Thanks so much for being here. I just have a question about like physician responsibilities and trends in like that kind of realm. So I just want to ask, where do you kind of see like physician responsibilities going in the next, like, say 10, 20 years in terms of like expanding or maybe becoming more focused? Because I've seen like a recent trend in like offloading some of the documentation and also some of like patient interactions with like medical scribes and physician assistants. But is there anything else that you see kind of like happening? Or because I mean, you talked about how there's new devices almost quarterly, and how do you manage like the exploding responsibilities of physician with properly offloading the tasks that can be offloaded?
Well, I think the biggest thing that's going to change healthcare is the new generations of people. I mean, historically, physicians were workaholics and proud of it, and they would want basically no life outside the hospital. I think the newer generations are much wiser and want more balance. So that's going to be one driving force. My hope is that technology will offload some of the remedial things that we have to do. In some ways, in the early 2000s, when EMRs came, electronic medical records, it made our lives far worse. But my hope is that with better, speech recognition and AI involved with some of the menial tasks that we have to deal with, that'll improve things so we can concentrate on what's more important. And then the other thing is, to your question, it depends on what specialty of medicine you're talking about. My view, it might be different than a psychiatrist's view. So my hope is in the future, technology will be solving some issues. Normally, it also creates them. But I think one of the biggest drivers will be the future generation of doctors who may want more balance in their lives, and maybe more wisely, they'll want to concentrate on what's more important.
Yeah, I think I could just echo that from Shawn's. Even as a PhD, I think you're seeing that more and more, that people do want a work-life balance. And, when you're caring for patients and you're on call and you can see you're scrubbed in right now and, answering this on the side, hopefully technology will be able to help with that. I think in the specialties, particularly when you need a specialist, you need a specialist. So I'm not sure there's much way of getting around with that. But I think there certainly is balance. And I know at our hospital, of course, there is a committee on physician burnout, which I'm sure is a real issue, as well, and probably at your hospital as well. So I'm hoping that you might think out of COVID, maybe we can have a more humane society. That may be a big ask. I'm not sure. That's, that may be a little euphoria, but, maybe that's something that we can all at least work towards.
Let me just
well said
in and talk about it. 1940s, the mortality from anesthesia was 1 in 1,000. 2000 to 2019, the statistics showed that the mortality has come down considerably to 1 in 100,000. And now the mortality, which I hear from anesthesia, is 1 in 300,000. Why did we have this mortality rate which has gone this low? It's because of the technologies such as gas analyzers, arterial pulse oximeter, electronic infusion pumps, advanced airway devices, portable ultrasound and echocardiographic imaging have reduced the mortality directly attributed, which was attributed to anesthesia. Now, let me just bring to your attention one thing about this technology using the ultrasound and identifying. If in case that in the past, what we did was, if in case that you have to do an internal jugular puncture for putting in a catheter or something like that, blind technique, you go between the sternocleidomastoid muscle and the division, and then you put in a needle and you go into the vein. By doing so, you are blindly probing the internal jugular vein to put in the catheter. Sometimes the needle can go into the internal the carotid artery, and you could have catastrophic problems resulting from that. What technology has done is, by using echo, that we will be able to identify the internal jugular vein, and by putting the needle using the ultrasound, you will be able to go straight into the internal jugular vein and put in your central venous catheter or Swan-Ganz catheter and things like that. And also nowadays, we use the ultrasound quite a bit for identifying the brachial plexus, identifying any blocks which we are doing. We are using ultrasound, and we are precisely putting the local anesthetic, and in that way that we don't have to give too much of local anesthetic. If in case that we had been using 20 cc's of 2% lidocaine or bupivacaine or of that type of local anesthetic blindly, we will be able to use only about 5 to 10 ml if in case that you are using ultrasound. The technology in our field of anesthesia has helped us quite a bit.
Thank you, Dr. Vinayakam. That was really insightful. I have a question specifically for Dr. Cleary. So I had the pleasure of attending one of his previous seminars for Children's National about Clinic of the Future and telehealth. So I would love if he could just like elaborate on something he found the most interesting and most exciting for the future of technology and medicine as it pertains to like Clinic of the Future and like what we can expect.
Yeah, thanks for the question. So we did do a session on Clinic of the Future last fall, and I think the website is almost done. I think I still have to approve it. So then it will be hopefully live so everybody can see that. But I think I'll talk about two things. One is just in general, I think what's happened with the pandemic is that everyone has accepted that Zoom may be a mode of communication. Of course, people would like to get together in person, but there are obvious advantages to doing a seminar like this today, where I might give you an hour or so on a Sunday when I can just call in from my office or home. But if I have to physically travel to a place, I might not do it. So I think that just the fact that telemedicine is possible, that telehealth is possible, that a virtual platform does have some advantages, obviously some disadvantages. But now towards that line, I think people who came to the seminar know that we have been working on what I'll call telerehabilitation. So for children with cerebral palsy who may have trouble walking and may not be able to keep up with their peers, they're typically provided exercise by a therapist. And like most of us who get physical therapy, they're not so compliant because it's boring and there's nobody there to watch them. So we have developed a little ankle robot that these children can use, and their foot becomes the pilot for an airplane video game where they fly through hoops and they get a score. So right now we have that in home trial. And unfortunately, it's a little big and bulky. What I'd love to develop now is a lower cost version, kind of like a foot mouse or a foot joystick, where these kids can then play video games against their peers and still be monitored by a therapist. So again, I think the possibilities for medical treatment virtually, for rehabilitation, to reach underserved populations, like you had discussed, I caught the end of the last session, are all possibility. So I would say the biggest trend is, that one should be first optimistic about the future, and then it's, what is the relevant use of technology? We have plenty of technology now. How do we use that in a relevant way? And also, consider the new things going on with health equities and things like that that need to be addressed.
Absolutely, great answer. I have a quick follow-up to that, but more towards like the seminar we had last time. I think it was Dr. Natasha Scher who talked about it, where there's like personalized kits getting sent to people's homes where they could provide self-care. Could you provide any insight on this to the people who weren't able to attend?
Yeah, we did talk a little bit about that in that session. So the idea is, if you want to do the virtual physical exam, how do you do that? So, for example, do you have a cell phone app that you send people that you say, scan yourself? If you can do a 3D scan now with your cell phone, and now, okay, I'm going to compute your vital signs, your head size, things like that, so that if I have a kid, and you typically look at growth charts for kids, which are 2D representations of how kids are progressing. Can I now have a 3D model of the kid and see how they're progressing over time? Can I have a little app that scans your eyes and checks that? Can you move your legs? Oh, I can't get my leg up high enough. But anyway, can you do that? And can you check joint motion, with sensors like that? So, what could go in that as well, and what could be done in a home healthcare environment? I think those are all topics that, will be available. And I think there'll be commercial companies exploring those areas in the future.
No, that's amazing. Yeah, no, for sure. Thanks so much for that answer, Dr. Cleary. Yeah, we can move it to one of my other moderators to ask another question.
So I can, I was, excuse me, sorry. So I was sort of wondering, if all of you could sort of briefly, talk about how, because I mean, this session is about like medical innovations. So how is it that your work or your unique practice is sort of changing how things are done today? And what changes do you want to make to the current medical practice and landscape?
Wow, I'll take a first shot again, but that's a very broad question. So, I think, yeah, sure, we'd love to have universal care for all, and have a system without so much paperwork, but I think that's beyond what we're going to accomplish right now. I mean, I think for us, just at a pediatric hospital, I mean, medical care is slow to change. There's probably good reason with that. You probably want your physician to be conservative and not try everything new. And, we may complain about FDA and regulations, but I think it keeps people safe for everybody. The vaccine rollout is probably a good example of that right here. But for us in pediatrics, really the idea is just, what can we do to make the kid's life better? It's difficult because pediatrics is a small market, so commercialization is tough. So I can't really give you a good answer to that question because it's very broad. But I would again say for any of you thinking getting into medical care, I did work for NASA. I worked for Department of Defense, and then I got into medicine about 25 years ago. And not that I didn't like those jobs, but I still feel best about the medical job. So I think it's just that we need a new generation of people, who are passionate to making healthcare better. And, I think if you have a career in this field, hopefully it will be rewarding for you and you'll be the people who'll be able to answer that question.
Thank you, Dr. Cleary.
Innovation.
Other panelists want to add anything?
Let me just talk a little bit about the innovation, which is new ideas, methods, or devices, right? That is basically what we are talking about. As an anesthesiologist, I worked in the field of outpatient, well, I should say that gastroenterology. That was one of the field I worked for about more than 10 years. Before I was the director of that unit, I used to hear mortalities happening in that area. By giving anesthesia, that people were not getting enough oxygen during the procedure. So what I'm talking about is procedures like endoscopies, upper endoscopy or colonoscopy and stuff like that, especially with upper endoscopy. And also I would like to bring to your attention a lot of patient population which we had in the gastroenterology unit for the upper endoscopic procedure as well as colonoscopies. They were morbidly obese. No wonder when we administer anesthesia, and the anesthetic agent which we had been using was propofol. Sometimes some anesthesiologists will use a little bit of fentanyl or narcotics to keep the patient not to realize the discomfort of when they put in the equipment, put in the endoscopes like the upper endoscopy or the colonoscopies and stuff like that. What happens is, especially for the upper endoscopies, we are sharing the airway. The anesthesiologist is going to administer oxygen, and the same airway, which is the oropharynx or the nasopharynx through which they are putting that equipment, is also going very close to the throat. And if in case the anesthesia is not deep enough, obviously the patient is going to cough, is going to go into laryngeal spasm, and they are going to cut off from the oxygenation completely. And if in case that you deprive the patient from oxygenation for a few minutes, you know what is going to happen. It is going to be death for the patient. Especially morbidly obese patients, it was very difficult to manage the airway when they are putting the scopes in, okay? Now, so I went and took charge of the endoscopy room, and we were having 6 rooms going at the same time. So I was thinking about having some way of preventing this oxygen problem from happening. So what I was doing, what I did was that I used a simple device called nasal trumpet. And I connected a endotracheal tube connection to the nasal trumpet. The nasal trumpet is a curved thing that you put through the nose, and the tip of the trumpet will be almost very close to the trachea. And when once you connect the nasal trumpet to a device called the Jackson-Rees circuit. I don't know whether you know the circuit or not because you are all students, which is basically a bellow with the oxygen connected to it and a tube which will be going and connecting to the endotracheal connector, which is attached to the nasal trumpet. You give the intravenous agent. The moment you give the intravenous, and you have to monitor these patients very closely, like your entitled CO2 monitor, your pulse oximeter, and then you very closely watch the saturation, and also I used to have another monitor called the BIS monitor, which was a blessing in disguise for me. Some of the anesthesiologists didn't believe in it, but I was using that BIS monitor, which is which gives the electroencephalogram, compressed way of electroencephalogram, which gives in the form of number. The awake patient will be having a number of 100, and the patient, when they are anesthetized, the number goes down to about 30 to 40. That is an indicator that the patient has gone to sleep. And at that time, I'm talking about normal, young, healthy patients. You don't have to worry about the airway that much. But even in those patients, sometimes you could get into big time problems. But we get a lot of obese patients coming to our side for the procedure. So what I do is the moment I give the inhalation agent, I gently squeeze the bag and make sure that I can ventilate the patient. I can see the chest moving up and down. The saturation stays almost 98 all the time. By doing so, you are achieving two things. One is that you are giving the surgeon who is working an ideal kind of condition where he will be able to do the scope properly, and he will be able to go and see what is in the stomach, what is in the esophagus, what is in the duodenum, and you can give them enough time so that they can take their own time to do their procedure. At the same time, that you can also make sure that your patient is not compromised in any way. As an anesthesiologist, I believe that should be the goal of any anesthesiologist. That is no harm to the patient. That these are some of the innovation which I made while I was working, and the people who are working under me, they always carried this nasal trumpet with the connector on it, and also a Jackson-Rees circuit. And they had come and told me several times, "Oh my God, what difference have you made by using this device?" This is one of the innovations which I have used while I was working in that unit. And the people who had gone to United States, all over United States and working, if you go and see them, they will be having the nasal trumpet and the connector and a Jackson-Rees circuit close to them all the time. See, that is one of the innovations which I made, which I used, and I worked in that area for about 10 years. I'm not boasting myself or anything like that. There were no mortality, zero mortality while I was working in Georgetown University Hospital in gastrointestinal endoscopy rooms.
Yeah, that's amazing, Dr. Vinayakam. Thank you so much for all that insight. You definitely provide a lot of things. I learned so much about anesthesiology and the nasal trumpet just from you talking. So thank you so much for that. This panel closes in a few minutes, so I'd love if Dr. Cleary could end off on a quick question. This is really general as well. But as a lot of us are pre-meds, could you give your insight on maybe some advice you'd like to give to us going forward, and like what should we look forward to in improving ourselves for the future?
Right. Well, if you're pre-meds, and I'm not I'm a PhD researcher, so I don't know if I want to give you advice about a medical career, but I think the general advice, is that you should still pursue what you want to do. I think the idea about pursuing your dreams, I mean, certainly at our hospital, I appreciate the clinicians who take care of the kids, and I think they find that very rewarding, and I'm sure the same is true for other medical practices. But, of course, that has to be what you want to do, and I think no matter what career you pursue, I mean, I think medicine is very rewarding. As you've heard, it's not without its challenges. Maybe we'll have a little bit of a reset with COVID. People will start rethinking the system. But I think, again, not to repeat this, but the key is to kind of pursue your dreams. And, if you're passionate about it, you'll do well. And then, I would like to encourage you guys to keep up these seminars. I think it's a good thing, to broaden your horizons. It's a good thing, again, during COVID and as we come out of COVID to meet new people this way and, explore ideas. So congratulations for putting on what looks like another successful event.
Absolutely. Well, that concludes our panel. Thank you both, Dr. Vinayakam and Dr. Cleary, so much for taking the time out of your day. I know Dr. Sarin had to leave a little early, but definitely thank you to him too. You guys are awesome, and I'm sure we all learned so much from you. So thank you so much for coming, really.
You're welcome.
All right. Good to see everybody. Yep. Bye-bye.
Now we will go to Adam Snyder for some closing remarks on the GW Health Summit.
Thank you so much. So I just want to thank everyone who was able to participate today for being able to listen in to all the different panels and discussions. And it's just really exciting to see how we've all been able to really come together during this time of COVID. The pandemic has really tried to separate us, but using different platforms such as Zoom to really bring to light a lot of educational opportunities and ways to collaborate with one another. Without the help of Shawn and the rest of the other co-hosts, none of this would have been possible to host. And with their help, we brought amazing doctors such as Dr. Vinayakam and Dr. Cleary, and we've been able to bring so many opportunities for students in a collaborative way. So I have to say a big shout out to all of them for making this happen. And just some last bits about the Health Summit is that this is just the beginning. We're hoping to have this similar event this coming fall, and more details will be coming up very shortly about that. We're working very hard around the clock. Hosting this event took months of planning and scheduling to make all this possible. And we really hope to make an even larger and more amazing Health Summit next semester to a larger and a higher summit, if that makes sense. Another really important thing is that understanding that this is brought to you by a coalition of student organizations that have the goal of improving health on campus and advocating for the health of students. So be looking forward to future opportunities to learn how to do CPR, AED training, biomedical engineering events, learning how to do different procedures on different surgery models that we've purchased through the help of the university, and we'll be contacting you very shortly about that. Thank you so much for coming. It has been such a delight and pleasure to be speaking with you all today, and just a really big thank you to everyone who's here.
And definitely thank you to everyone. Adam's speaking really like altruistically and saying thank you to everyone who participated in this, and that's absolutely true. I'd just like to take a second from all of us to thank Adam for putting in all the months of work to put this all together, get over 10 speakers from the most prestigious backgrounds, putting this all together. And we're really happy with the result. And Adam, we can't do it without you. And we look forward to whatever you put out in the future. Thank you.
Thank you so much. It really means a lot to you, Shawn.